computer. All right, so it is June 6th. It is the day back after holiday, and I'm going to turn this over to Dr. Reskin because she has some wonderful things to say with her French hat on.
Yes.
Oui, oui.
Bonjour. Bonjour. How is everyone? I hope you had a good holiday. Today's the day. Can you guess what today is? Today's the day you've been waiting for since day one. Drug testing day. Yes, well, it's drug testing 48 hours. So let me share my screen. So everyone prepaid for a drug screen at the lab right next door to the PTA suite, which is where I am right now. I don't have a virtual background today. I have a virtual hat, but not a virtual background. So you've already paid for the test. And I'm announcing right now you have 48 plus 3, 51 hours to go and get drug tested at the place. Well, you bought it online, but it's an actual office and it's the suite right next door to the PTA suite. Okay, and so you have 51 hours to go and get drug tested. If you do not make it in there before 4 o'clock on Thursday, unfortunately, that will mean that will be taken as a refusal to get drug screened, and that's a termination from the program. It's called ARC Point. Yes, it is called ARC Point. Let me share my screen to show you what you need to know. It's not very much. Okay. So basically it's 48 hours, but I'm giving you until the end of class on Thursday, and ARC Point closes at 4. You can't go in there after 4. So you have until 4 o'clock on Thursday to go in there and get drug tested. Okay. They open at 8:30 and they are expecting you. You can do a walk-in. You do not need to call and make an appointment. So you can go when it's convenient for you, but you do have to go. All right. You cannot attend clinical rotations without doing your drug test. And okay, I will. So of course, Randy's just stopped by. He wants to talk to me, but I'll talk to him when I'm done. What was I saying? Oh, so you can't go to clinical rotation without getting without passing a drug test. Okay. And, this is when you're called to do a drug test. So failure to complete the drug test before 4 p.m. July 8th is equivalent to refusing a random drug test and results in termination from the program. Okay. And this is something that you agreed to in writing in several places before you enrolled in the program and after. Please do wear your PIMA uniform so they know who you are. You do need to bring your PIMA ID because you signed up using your name. And so you need to show them your PIMA ID so that they know what program you're in and to send me the results. Otherwise, they won't know who at PIMA to send it to because they drug test everyone from main campus in the respiratory and pharmacy and all those programs too. Okay. If you have, used things that are not allowed, don't try to flush it out of your system. They actually test your urine for too much water or too much anything that people use to try to flush substances out of the urine. Okay. If your urine contains too much water, that's fail. All right. So don't start drinking tons of water. There's nothing you can do. They test for everything, including attempts to change the results. When you go in there, do not be rude or argumentative to the staff. Don't argue with them. Don't be sarcastic with them. It's not going to help you pass the drug test. Okay. That's not going to change anything, but it can get you suspended or terminated from the program if you were unprofessional with them. I've been working with them personally for 8 years, and they've been working with PIMA since PIMA opened, which is, 15 years. Okay, so we have a relationship. We know each other. I know them, they know me. So don't try to, pressure them into anything or talk them into anything or beg or threaten or anything like that, because it's just going to get you removed from the program. They have very specific COVID-19 procedures. You cannot just walk in the clinic. You walk up to the door and you have to call them with your cell phone to tell them that you're here, okay? And then they'll let you sign in and you wait outside under the covering. That's right outside Mr. McKeever's office, okay? And then they'll come out and get you when they're ready for you. I see a chat. Right, so you do not need, there's no appointments. You just go to the door, call them with your cell phone. They're gonna look out and see you. And I'm sorry, you can't see me smile. Then they will let you in when they're ready for you, because they can't have people sitting in the waiting room. They don't want people clustering or not socially distancing yet. They're a medical facility, and so they have these rules, which are very logical rules, okay? You do need to wear a mask as well, even if you have been vaccinated. Do not try to go in there without a mask. Those are their rules. You need to follow their rules. So wear your uniform, bring your ID, your PIMA ID badge, and wear a mask. And you need to have your cell phone with you too. Sometimes students say, oh, I have to work in the morning and then I have class in the afternoon. So I can't go, and that's not an excuse. You have to go. Because as I said, if you do not make it in there by 4 o'clock on Thursday, that's taken as that's a unstated refusal to take the drug test. So you have to make it work. If you need to go during class, like let's say you work from 8 o'clock in the morning until 12:45, and then you're coming into class, you could still go at 12:45. But let's say you work until 12:55 and then you run into school or you run home to take class, talk to me and Mr. McKeever and I will work out a time for you to go there during class. You'll just have to miss class and you'll lose PPS points because you're not in class. Okay, so this is, do we email you after taking the test? You don't have to, because they will email me the test results. So, oh, sorry, I see another chat. Let me see here. Oh, okay. Let's see. So 8:30 a.m. to 4 p.m. That's when you can go. No excuses are accepted. This is the drug test. This is for real. This is not an assignment. You can't do it late. You can't put it off. This is it. This is the only time you can do it if you want to continue in the program. It's mandatory when we call people for a random drug test. Okay, it's not negotiable at all. So sorry to be, so serious, but this is a serious matter. Now, does anyone have any questions? Let me just show you those bullet points again. Any questions about the drug testing? Not having a car is not an excuse either. There's other modes of transportation. Let's see, will we have one randomly before each clinical, or this the only one? Yeah, we don't tell students that. We can randomly drug test at any time. Okay. If you thought, oh, we're just in classes and it's really chill and PIMA's an easy program and I can do whatever I want, and they're not going to know. We will know. We will know. This is serious, and this is where you have to start acting like a real clinician and not doing, drugs, medication, substances that are not allowed in the clinic. And you notice I'm not saying things that are illegal or legalized, because some things are legalized or some things you can do, like alcohol is legal, but you still can't be under the influence when you're in the clinic. Well, it's the same for class. You cannot be under the influence when you're in class. So even if certain things are legal, but they're not allowed in a healthcare clinic and they're not allowed in school, then this is something that you knew about coming into the program. And so it's a commitment that you make to be a healthcare practitioner. Do we need to bring the printout of the receipt when we purchase a drug test? You can, but you don't have to. They have you in their system. You do need to bring your ID. And, I would bring your driver's license as well as your PIMA ID, but they usually are okay just with your PIMA ID because they want to see what program you're in. Any other questions? And then, of course, PIMA always has the option of doing what we call a for-cause drug test at any time. So even if you have done this one, if your behavior or your presentation or the way you're dressed, or you come in unwashed and dirty clothes. I mean, if there's anything that makes us think that you might have been using substances that you're not allowed to, we can send you for a drug test at any time that you're in the program, and so can your clinic. So if you arrive to clinic and they're concerned about your behavior, your speech, your presentation, how you're dressed, they can also call me and I will send you for a drug test to make sure that you're not under the influence or you have been using something that you agreed not to use to be in healthcare. So any other questions?
Hey, Dr. Reskin, I don't like peeing in a cup. Can I request a hair test instead of a pee in a cup test?
I don't think so. The answer is no.
What about drugs that might pop positive that I have prescriptions for? Should I be ready to explain those in case those pop up on my drug test?
Yes, those will show up in your drug test, and the doctor from the lab will be calling you to verify if you have an appropriate prescription. Just because you have a prescription doesn't mean that the amount that they find in your urine is appropriate. So they'll be checking for prescription for anything like that. Great question. Student Keith?
Wow, that's awesome. I'm so glad you're on top of this.
Oui. Bien sûr. Oh, I see a chat. Oh, good. I'm glad we're making you laugh there. Okay, any other questions? You can always email me with questions too. If you don't think of your question right now, or you don't want to ask it in front of everyone, that's fine too. So, all right. Okay, so this is where everyone's like, oh my gosh, Dr. Ruskin is mean. And I'm not mean, I just have to follow the rules. And I have to send the clinics what they ask for, and they ask for drug test results. So, all right. Bye, everyone. Bye, Mr. McKeever. Thank you.
Thank you, Dr. Ruskin. She goes, all right, I'm going to take back over control of the screen. Haha, I'm back. All right. So now that you're all scared, I may have a solution for that, and we'll talk about that at break when we're off recording. So relax for that for a few minutes. So we have 2 chapters yet we have to cover in TherEx today. And this will be your kind of final TherEx lectures. And those are Aquatic Therapy and kind of circling back to talk about spinal therapy basics for exercise. We've already kind of covered that in kinesiology, but we've got to come back and kind of circle a little bit of it for therapeutic exercise. So we'll hit a few of those. Again, not going to hit a ton because Dr. Reston's going to hit a lot more next week. Or not next week, but next semester, but we will hit some exercises today. We'll probably finish with doing a really good session of stretching out our necks at the end. We'll go through all the general neck stretches to take the stress of having to get a drug test off your shoulders. Study really hard. The questions on the drug test are really hard. I'm just letting you know. No, I'm just joking. Okay, good. All right, so let me bring up and PowerPoint here. Yeah, it's because I just edited it, John. It should be uploading in the next few seconds. I realized I didn't change the title slide on it. And so I went and changed title slide on it because it still says Aquatic Therapy for some unknown reason. So I just edited it. I did the edits. And it should be uploaded shortly here. We're going to start with Aquatic Therapy anyway. All right. Get everything out of my way here. I got all the slides up. I got all y'all up. All right. So aquatic therapy, that basically means pool therapy, right? And I'm sure probably if I ask most of you, how many of you guys would like to be paid for 8 hours a day of spending time in the pool? You'd all be like, yep, sign me up. Right? Raquel's like, for sure, right? You do turn into a prune. I will give you that. It's, now good news is you don't spend all day in the pool, but what's great about it is you spend enough time in the pool to get accustomed to the temperature, only to get out and be cold and then get back in the pool again. That's kind of usually the way it works in aquatic therapy, at least my experience is. Fruits are good for you. Yeah, they definitely cleanse you, right? So what is aquatic exercise? Aquatic exercise is the use of water to facilitate therapeutic interventions. So everything we do on land, pretty much you can do in the water. You can do stretching, strengthening, joint mobilizations, gait, balance, endurance, cardio training, plyometrics, weightlifting. Pretty much everything you do on land, you can do back in the pool as well. It's just going to be a little different because, again, it's going to adjust your overall, buoyancy, and we're going to talk about all those fun topics here coming up on how things change when you're in the pool. So what are some indications for pool therapy? Well, some of the indications are to initiate weight bearing. So if we've got a patient that maybe has a total hip replacement and they can't fully weight bear on land, maybe they're partial weight bearing. Well, we can actually do weight bearing in the pool, almost full weight bearing, because there's a certain level that we can take them up to that reduces the level of weight on their legs. Resistance training, endurance training, all may be started when they're prohibited on land. So, maybe we've got somebody that's not quite healthy enough to begin, kind of resistance training on land, but we can move them to pool therapy, which reduces the overall workload on their muscles themselves. Initiate functional training. We can do functional training like transfers, everything else like that in the pool, as long as we don't drown our patient. Minimize injury. And I want to say this is minimize injury not only to the patient. Where'd my little cursor go? I love when I can't find my cursor on all my screens. Right? But also to the PTA. Because specifically, I'm thinking of myself when I work with some of the kids I work with. When I work with some of my children that have muscular dystrophy, those kids can be pretty big kids. I remember the one kid I've treated for most of the time I've been here in Vegas. The last time I saw him, he was like 5'6" and close to 260. He's a chunky monkey. And getting him up and standing him on land wears me out, right? But I can get him in the water and I can move him around like crazy, and he can move around a lot better because, again, weight resistance or weight reductions there. It also gives you a three-dimensional access to the patient. If I'm working with Anthony and I want to mobilize his spine, and again, not spinal mobilization, but just mobilize his spine, it's really hard for me to mobilize his spine when he's in standing or even in supine. But I can get him floating on his back, and I can move his spine to the right and to the left really easy when he's floating in the water. So it gives me a really three-dimensional access to that patient, which is nice. It can really enhance manual therapy and range of motion because of that last statement there. It relaxes the patient. Now, not all patients are relaxed in the pool, but a lot of them do relax when they get into the pool. And it's funny because I find with kids, for whatever reason, they really just love getting in the pool. And so they're a little bit more compliant with therapy when I ask them to get in the pool. And they're more willing to do all of their therapy if they can like do a belly flop and splash me at the end of therapy. Whatever works. But what are some precautions for it? Fear of water is a major precaution. I would almost add that up to even a contraindication, depending upon how severe it is, right? Hydrophobia. Neurological disorders, right? Something like seizures. Could that be a problem if we were working in the pool and they suddenly started having a seizure? Yeah, right? What are we supposed to do if a patient has a seizure? Lie them down and give them clearance. Let them have their seizure. If we lie them down in the pool, they're laying on the bottom of the pool. That's not always a good idea, right? Even if we get them floating in the pool and let them have their seizure, water's still splashing all around, they can drown. Certain cardiac conditions and respiratory disorders are going to be precautions as well, especially where we have cardiac conditions that are overloading the workload of the heart, right? So we've got really, really bad heart failure, or we've got, respiratory failure disease, something like that, or even some kidney diseases, which we're going to talk about as contraindications. We have to be careful when working with the patient in the pool. And then small wounds, right? So small wounds being, little itsy bitsy scrapes, cuts, those are okay. We can even get a patient, and I've done this in the hospital, get a patient in a pool that has an IV in. As long as we take over the IV and we provide protection to that IV site, they can get in the pool as long as we're aware of it and we protect it. Why would kidney disease be a contraindication to therapy in the pool? What do you guys think? Any ideas?
Hydrostatic pressure?
Yes, hydrostatic pressure. Good, right? Because I guarantee you, and I'm sure all of you have encountered this at some point, where you get ready to get in the pool, and as soon as you get in the pool, all of a sudden you're like, oh crap, I gotta pee, right? And then you pee and the water turns dark blue around you. No, just kidding, don't do that. But yeah, so the pressure builds up and that can affect your kidneys, right? It can also put some extra pressure on those kidneys, which can be bad. Again, certain cardiac and respiratory conditions go along with that. If the patient is incontinent of bowel and bladder, right, we don't want them getting in the therapy pool. What happens if you have an incontinence issue in a pool? What do we actually have to do to the pool?
Shock the water?
Yeah, it's shock the water. We have to basically shut the pool down for a period of time. And you can think about that if you've got patients scheduled to do pool therapy all day long and you have to shut down the pool for 2 hours or 3 hours or whatever the shock requires. Problematic, right? We don't want baby Ruths floating in the pool. So Riley asked a good question. What about swim diapers? We have them for adults as well. They do exist, but for therapy pools, those are still kind of a no-go just because of the whole, what if their urine has some sort of a virus or bacteria in it that could infect somebody else, right? We're splashing around in the pool and all of a sudden their urine gets in your eyes, Riley. That could be bad, right? Even the diaper is not going to absorb all of it. Some of it's going to disperse around you. Now, the pool should take care of most of it, right? We know this, but we'll talk about a specific condition that happens pretty good. Really open wounds or healing surgical incisions should not be in the pool. And when I say open wounds, I'm talking big gaping nasty wounds, right? Especially things like total hip replacements, total knee replacements, back surgeries. Those patients should not be in the pool because the risk of infection of those surgical sites is really high due to Pseudomonas, which is kind of natural in pools and hot tubs. Certain infection diseases, maybe a real severe case of MRSA, or there are some other conditions that exist out there that are really highly transmissible. I'd be willing to bet COVID is even in there on that. I'm not so sure. I don't know if COVID's a hard contraindication of pool therapy or not, but I don't know if the chlorine in the pool kills COVID. I assume it would if Clorox kills COVID. I'd assume that most of the stuff in the pool would kill COVID as well, but yeah, I don't know. Seizures and then hemorrhagic diseases where the patient bleeds out, probably not a good idea to have them in the pool, right? So there are some reasons why we won't do pool therapy, but for the most part, most patients are okay to get in the pool. I've even gotten patients in that have fear of water. I just have to give them graded exposure, right? If I'm working with Riley and Riley has a fear of water, I don't want to take her in the deep end. Now, there are some psychological theories on that as well, but we're not going to do that. We are not psychologists in the PTA field, right? We are physical therapist assistants, and our goal is not to terrify our patient out of their phobia. The goal is to give them a good therapeutic event. So if we maybe only have to go up to their waist, okay, we go as far as we can go that they'll tolerate. Most patients that have a fear of water have a triggering event, right? Most of the people that have some sort of fear, whether it's fear of water, fear of spiders, unless it's kind of an irrational fear, they've had some event in their lifetime that caused them to have that fear. Maybe they had a near drowning event. Maybe they had a family member that had a near drowning event. They have reasons they're typically afraid of water, and you have to listen to those reasons and be very empathetic to them. Understand why they express their conditions or their concerns, and then maybe also lay their concerns saying, hey, look, don't worry. We're not going to go down in a 7-foot deep section, right? We're staying right here where it's 3 foot deep, that it's only up to your waist. You can do this. I have faith in you. This also brings up that when I talked about incontinent patients here as well, but not only just incontinent patients, but before your patient gets in the pool, what are some good things they should do?
Go to the bathroom.
Yes, go to the bathroom. Right? And that means number 1 or number 2, because both of those can happen when you get in the pool. Right? So if you think you might have to, yeah, there we go. That's right. So shower. This can include potentially showering the hair if your hair is going to get in the pool, because certain chemicals in hair products can affect the pH of pools. So they definitely need to shower. They also have to have appropriate swimwear. So we're going to talk about this from 2 perspectives. First, we're going to talk about it from a patient's perspective, and then we're going to talk about it from our perspective. So from a patient perspective, the swimwear they need to wear needs to be swimwear. It can't be cotton shorts. It can't be, rayon shorts. It can't be nylon shorts. It can't be bike shorts. It can't be, what did I see the other day? I was at the pool. There's a lady wearing yoga pants in the pool. I'm hoping they're like swim yoga pants, but I don't think they were. Yeah, they can't be jorts, right? They have to be appropriate pool swimwear. And there are reasons for that. Specifically here in Nevada, when I do pool therapy, I don't have an aquatic pool to do my therapy in. So I usually go to the Clark County pools, right? The clothes will be too heavy, number 1, good, right? But I do a lot of the Clark County pool system, recreational system they have. So like the Sunrise pool, there's one out in Hollywood pool. That's one I usually take my patients to. It's out of the way. But their filtration system gets messed up if you wear cotton type materials into the pool, because those cotton fibers do kind of shear off a little bit, and then it blocks up their filtration system, and they will not let you get in the pool with it. I usually try to do a pool therapy session if COVID wasn't around. Obviously, maybe we can do one next semester once we're back. But one of the things I had a student once that tried to get in with swimming trunks on, but he had boxers underneath the swimming trunks for, I don't know why. And of course, he had the boxers showing under his swimming trunks. And the lady from the pool came over and just like lost her head at me because he had boxers on. I wasn't looking to see if he had boxers on. That wasn't something I was constantly thinking about, honestly. I don't look to see if my students have boxers on. It's just not something I think about. I'm more cognizant aware now, right? So patients have to have appropriate swimwear on. Now let's talk therapist swimwear. Let's talk men first, and then we'll go to ladies. Men, appropriate swimwear. What would you consider appropriate trunks to be? Anyone have any ideas what you consider appropriate lower trunks to be for men? Just above the knee. Yeah, good. Right? We do not wear Speedos in the pool. Right? I once joked with Dr. Reskin, and I had her all nervous because she usually goes to the pool with me. I came out of the locker room and I had a towel around my waist. I'm like, I decided to wear Speedos today, Dr. Reskin. And I pulled my towel off, and the shorts that I had on were made by Speedos, and it kind of made her nervous initially. She's like, I thought you were trying to show the patient and students know what not to wear. I'm like, no, I'm not wearing Speedos. It's not happening. Yeah, she lost a little bit. It was kind of amusing. That was my little bit of torture. Sometimes I like to torture Dr. Reskin. Yeah, he didn't pee my colors. No, John. No pee my color Speedos. Right? No, like, if you're working for ATI, no ATI black and red Speedos. You can't do it, okay? So appropriate shorts wear is typically just above the knees is good. And when I'm working in the pool, if I am a medium person, meaning I wear medium pants, I usually buy a large pair of swim trunks for pool therapy because it gives me more mobility and it also gives me a little bit more coverage. I can always tie them tighter and keep them on me versus not. That also brings up the other thing, guys, and actually girls, please make sure your swim trunks are tied tightly. Don't just let them on you. It means make sure your strings are in good order and stuff like that. Also, men, I do highly recommend buying Rashguard shirts. Does anyone know what a Rashguard shirt is? I didn't know originally, so it's okay if you don't. Yeah, so Riley's like, yeah. So a Rashguard shirt is typically something that people wear when they're surfing, right, Riley? That's where I take it comes from. Or surfing or bodyboarding, right? It is a shirt made out of swimsuit material primarily. It's usually a neoprene or something to that effect. They don't have to be form-fitting. I found one that is not form-fitting because no one wants to see my form anyway. And why do you think it might be appropriate to get a shirt? Specifically working with which population? Guys. Good. I saw somebody popping in. Kids, yeah, and women. Good. Yep. Kids and women. Sometimes older people, Bianca, but not very often. But yeah, sometimes it might be, if you don't want that little lady to tweak your nipple, it might be a good idea to wear a shirt. But it's just one of those, especially with kids. And what I found is, especially when you don't know the religion, right? I'm going to take, for example, where I come from back in Pennsylvania. We have a religion there that you guys don't have here, and that is Amish, right? There's not a huge Amish community in Las Vegas. I don't know why that is. It's almost like they wouldn't be able to survive here in Las Vegas, really, as an Amish community, right? I mean, let's face it, they don't have electricity. They're going to cook out here. And there's not farmland here. But in the Amish community, if you're working with a young female, say Brooke was an Amish girl who's, say, 14, she actually cannot see a topless male, or it puts her at risk of being shunned by her community. And I'm not even joking about this. I'm actually being 100% serious about this. She couldn't see a topless male, or it puts her at risk of being shunned by her community. So I had to learn a little bit of different kind of appropriateness for working with kids of different religions. We have Amish and we have Mennonite back in Pennsylvania. And we also have a really, really large Somali community back in Pennsylvania. So I had to learn a little bit more about dealing with people of Muslim faith and dealing with pool therapy. And that's a totally different world, right? So you have to be cognizant of that, guys. It's not that I don't appreciate Orthodox Jews too. Thank you. Yes, Riley. Didn't even think about that, but you're 100% right. You know, it's not that we don't want to see John's guns being shown off in the pool, right? He just has to take his gun show down a little bit and put a shirt over them. And it's just to protect yourself. Do you always have to wear a shirt in the pool, guys? No, you don't, but I tend to nowadays. I got water guns, yeah. I just tend to, whenever I do pool therapy now, I just have my Rashguard shirt on. And I've actually got a couple of them now. Like I got a SpongeBob one, and I've got a couple other ones that kind of are for, you know, doing therapy with kids in the pool. Now let's talk ladies. My wonderful opposite sex partners here. What would you say is appropriate for a lady for swimwear? For pool therapy? Yeah, one piece is ideal, Bianca, 100%. Right? I have to learn. Yeah, I've had those board shorts and a rash guard are okay. Absolutely, Stephanie. One piece with shorts, as long as those shorts, again, Mara, are appropriate swimwear shorts, right? You can't just be cotton shorts. So all of that's okay. The other term I had to learn, which I didn't know, was a tankini. I had no idea what that even was. Those are typically okay in most therapy gyms. What would not be appropriate in a therapy gym? Yeah, bikini. No, so Brooke asked a good question. The shorts have to be above the knee for women. Not really. The shorts, as long as you have something on underneath them, Brooke, you're usually okay. Right? And that's the problem with guys, is guys don't exactly wear bottoms underneath their swimsuits, right? String bikinis especially, yes, Sydney. So allow me to tell you Mr. McKeever's embarrassment here, because this will tell you, I have said many times before we go to aqua therapy to wear appropriate swimwear. Because when we go to the aqua therapy class, and if we do it with you guys, which I hope I still will get to do it next semester with you, we do plyometrics in the pool. Okay? No, I did not wear a tankini. But 3 cohorts in a row, somebody ignored my rules of wearing appropriate swimwear because this bikini looked so cute on me, and I just wanted to show off for my whole class. And all 3 times, Mr. McKeever tends to work over towards that person, because I know as soon as we do a plyometric drill, one of those parts of that bikini is coming off. Yes, Raquel, right? So there have been 3 students now that unfortunately I have had to shield from the rest of the class, because I tend to be the largest body in the class, when things have popped off, or out, I guess would be the appropriate term. So if you want to be awkward like that and have to look at me in the face for the next 2 semesters after your body parts pop out, feel free to wear a bikini when we go to anatomy or go to pool therapy. But just remember, right? That's not something any of you want to have to do, correct? I'm assuming you don't want to ever have to be like, oh my God, did I actually do that in the pool? Right, Brooke's like. So in the pool, not typically, Riley. It depends though, again. It may depend on religion, right? If you're working with a kid that's got a religion, or a family that's got a religion that's anti-tattoo, you may have to. Right? So most of the time not, but I'll say this. And honestly, Riley, I will say this, in the clinics, it's becoming a little bit, yeah, shoulders are okay to show, sure. And I'm going to talk about that in a second, actually, Brooke. So I'll circle back to that in a second. Tattoos are becoming more commonplace in the clinic. Yeah. So tattoos are becoming more commonplace in the clinic. That doesn't mean all patients are okay with tattoos. right? Now, none of you have ever seen any of my tattoos, and that's on purpose, because none of you will ever see any of my tattoos. That's also because I don't have any, but none of you will ever see my tattoos, because tattoos involve needles, and Mr. McKeever is not about needles at all. I can stick people fine with needles. I'm not getting stuck with needles myself. But just be aware of that, right? How do I put this without being impolite? I'm just going to try to use the most PC terms I can use. If you have a tattoo on your lower back, specifically at the region of your PSIS, it may be best to wear a suit that covers that. Just because tattoos in that area tend to have a negative connotation. Is that a good term for it? It's as much as I can say without kind of going, yeah, right? Exactly. That's about as far as I can go without getting any further. I hope you guys are picking up what I'm putting down. Right, so be aware of that. And then Brooke asked a good question about, are shoulders okay? They are, as long as, again, we take into account any religious beliefs, right? So, for example, I'm just going to use you as an example here, Brooke. If I am a traditionalist Muslim, then no, it would not be okay for you to show shoulders to me. And honestly, if I'm the director of PT, I'm not going to put you with a traditionalist Muslim male. Just like I'm not going to put Anthony with a traditionalist Muslim female. I'm probably going to flop you, and Anthony will work with the guy, and you'll work with the wife. Because it's just still that way in certain, I get the hiccups, I'm sorry. Still that way in certain religions. Does that make sense? So just also be careful what you're advertising. There's a good term for it. Right? Just because, and again, please do not think this is me saying that if you wear XYZ, that this is okay for this to happen. That is not what I am saying. Please. I don't want, that's one of the biggest kind of caveats I worry about when I bring up this topic is that, I always hear the term, well, just because she was wearing it at the bar, she deserved it. No, that's not what I'm saying here. What I'm saying here is you have to think to yourself to the lowest common denominator person you could work with. And just be aware of that, right? Not all people have good intentions is kind of what I'm saying, right? Now, that doesn't mean every person you're going to encounter is going to be perverted or rude or something like that. But Anthony will find he's going to be the favorite of some of those little old ladies, I guarantee it. So does that make sense for the suits? The other thing also I usually get questioned about is, what about footwear? Can I wear, what are those shoes called? Water shoes in the pool. I tend not to wear water shoes in the pool because what I find is I actually lose traction with them. Even though they have traction built in, I'd rather have my whole foot that I can feel the whole bottom of the pool, right? But it depends upon your clinic. So if your clinic says you've got to wear water shoes, then you've got to wear water shoes, right? And then once you get out of the pool, you should also shower off as well. Why is it a good reason to shower off after getting out of the pool? Other than it prevents you from, smelling like a chlorine bath the whole day. Well, think about it. If there's anything in that pool that's viral, bacterial, or anything like that, at least showering off, you have a chance of rinsing it off before it gets in you. I know you guys probably don't think about that, and I don't think about it when I'm at like a regular pool. Yeah, it clears off any excess stuff, right? I don't think about it when I'm at a pool. Like, I just get out of the pool and get in my car and go. But then I started realizing, well, there are little kids that peed in this pool. I probably should shower off before I get, in my car. Towels, just as a thought process here as well. If you're working in a clinic and you bring your own towel, please make sure your towel is appropriate. Budweiser, not appropriate. Viagra towel, not appropriate. I don't know what else to, like, I can't think of anything that would be really inappropriate. Like, you know, swimsuit bikini models, maybe not appropriate on your towel, right? But definitely, you know, that's plain. I usually use a plain black towel because that's the way I just kind of cover it. Or I have a bunch of tiger towels I like because the kids love the tiger towels. Does that make sense, at least for appropriate swimwear and stuff like that? I know I covered that ad nauseum, but I just want to make sure that you guys are aware of it. All right, some physical properties of water. Well, we have the hydromechanic. Do I have patients? Yes, absolutely, John. Yeah, I know of at least 3 clinics in town that have small therapy pools.
Okay, so they don't usually have like they go out to like a public pool or anything like that. They have their own.
Well, it depends. I know that one of the clinics in town does do a weekly class at one of the local pools. So they bring like 3 of their therapists in and they rent part of the pool out for that day. So, I mean, yeah, usually it's in clinic though.
Okay.
Yeah.
Thank
you. Yeah, no problem. So hydromechanics are the property and the way water works within Newton's basic principles and laws, right? So Newton, for sure, all of his laws, the law of inertia, you know, the law of reaction, counteraction, all of that apply in the pool. One of the big ones we talk about is buoyancy. Buoyancy is the upward force that you feel when you're in the pool. It's the opposition of gravity. It enhances the ability to move because it displaces weight. And we have this good old principle called Archimedes Principle. And what Archimedes Principle says is your upward push, the amount you're pushed up in the water, is equal to the volume of water that you displace getting in the pool. And we've all done this, right? You've all filled up your bathtub and got it fairly full and you're getting ready to get in and soak in the bathtub. And you get in and you maybe overfilled it a little too much and you realize, oh crap, if I lower my whole self into this bathtub, it's going to overflow. That is kind of Archimedes' principle, because that's saying that your body is going to displace a certain amount of fluid based upon your body mass, your volume that you're taking up. Now, that being said, adipose versus muscle, which one floats better? Yes, adipose floats better, for sure, right? Well, why is that? Adipose has a high water content. So you've already kind of got basically a flotation device if you're high on adipose. The higher your content of muscle in your body, the greater the chance you have to sink, right? So if we put Truman in the pool right now, he'll just sink right to the bottom. We just know this. It is known. All right, fine. Facts, exactly. Not after quarantine. So just be aware of that because, again, if you have patients a little larger, that buoyancy might be greater. So it might be harder for them to maintain balance and stuff because of the water pushing them up. Hydrostatic pressure is the pressure that water exerts on an immersed object. Air around you exerts a certain pressure on you. Water exerts a greater pressure because in the air, the molecules are spread far apart. In water, they're closer together, right? And the deeper you go in water, the greater that hydrostatic pressure. Have any of you ever gone like either free diving or diving actually in the ocean? No? No one's ever gone diving? Just all stuck here in Nevada? I like to free dive when yeah, okay, good. Thank you, Riley. I appreciate it. At least somebody has. Okay. I like to free dive. I love going to the Bahamas and going down there and free diving, right? But it's funny because when you dive down, or maybe you've gone into a deep pool where you've gone all the way to the bottom and your ears have popped because you went so deep in the pool. Well, that's the hydrostatic pressure. That's all that is. Your ears have to regulate just like if you're going high in a plane or high up on a mountain, right? Your ears kind of pop doing that as well. So that also brings into effect that, if you're doing any type of underwater work with the patient, you have to be aware of that if they don't have the ability to equalize their pressure in their area. The Pascal's law states that pressure is equal on all sides of the object and increases with density of water and depth. So is cool water denser than hot water?
I think they're the same, aren't they?
No, slightly denser. Just slightly, a small amount. It's very, very minuscule, though. Good guess, Riley. The most dense water can be is about 4 degrees Celsius. And we're never going to put a patient in 4 degrees Celsius water. That would just be silly, right? Unless you're doing that polar plunge thing. And I highly recommend, if you've never done one of those, do one. It's a lot of fun. Just don't have a heart attack. So yeah, the cooler it goes, the more dense it gets. But again, in a therapy pool, there's not going to be that big of a difference in temperature that you're going to affect the density. Depth, yes. The deeper you go, the greater the pressure. So that means if I've got a swollen leg, so maybe I've got lymphedema, and I've got really, really bad, almost elephantiasis, where that leg is huge. Could I have that patient walk in the pool back and forth several trips to help flush some of that fluid out of that leg? Yeah, right? It's kind of interesting that we can do something as simple as putting them in the pool. I'm going to mute my thing so it stops beeping at me, to affect their fluid reduction. Now, the thing is, if you got somebody like that, I guarantee they start doing therapy. After about 5 minutes of therapy, if you have a lymphedema patient, they're probably going to have to pee because that fluid's got to go somewhere, right? But yeah, we can use that as an advantage. Let's say that Anna is recovering from a total knee replacement and she's a couple weeks out. So she doesn't, her surgical incision's healed, she's looking good, but she's still got increased swelling in that knee. We could do aqua therapy, do all the stuff we do on land, add that hydrostatic pressure around her knee, which then helps the swelling and push that fluid and all that stuff that's stuck in there out of it and maybe help reduce her swelling. So yeah, we certainly can. The viscosity is the friction between water molecules. It resists the flow or going against the flow. Again, back where I'm from, we have these things called rivers and creeks and cricks. Creeks and cricks are two different things, just to let you know. A creek is a pretty wide body of water. A crick is a tiny body of water. All of them have a flow. I know here the closest thing you can compare them to is a wash. Maybe some of you have seen rivers when you're flying over the country. I'm just messing with you all. It's kind of fun to mess with you guys like that. I also mess with people when I'm like, back in the East Coast, we have things that are green. But there's a flow that works with water, right? Water always flows from areas of heavy resistance, least resistance, just like any other substance, right? As that flow increases, or that velocity of fluid increases, it will increase resistance. So much so that we've now developed little mini pools, right? Haven't we? Those, I can't think what those pools are called, but they have they're basically hydrojet pools that you don't have to have a full-size pool, and you can have a little kind of bathtub-sized pool and still swim and get a good workout from it, right? You don't have to have huge pools if you don't have a lot of space. So components of the flow motion, right? We have laminar flow. Laminar flow is what you typically experience when you get into water that has any type of movement, right? So laminar flow would be something that you would experience if you stood in a river. It's water that's moving in kind of a parallel, slow direction. I mean, slow, some rivers can be pretty fast. Turbulent flow. When I think of turbulent flow, I think of whitewater, or I think of what it looks like when the waves crash onto the shore, right? It's very chaotic and fast. And if any of you have ever gone whitewater rafting, you know that turbulent flow can be really dangerous, right? Because usually you have turbulent flow going on top of the water, and then you have laminar flow that's really fast underneath the water. That could be a really dangerous scenario. And then you have drag. And drag is the combined function of an object resisting a specific flow. So if I had high force jets in the pool pushing against me, drag is nothing more than my inertia in water. Going back to physics, right? Could I turn those jets on so fast that eventually they knock me over? Sure. Yeah, I mean, most pools aren't going to have that much forceful jets, but yeah, I could, right? Could I get in a river where the flow of the river is more than I can resist? Sure. Right? Same thing with the ocean, right? If you're ever going out and swimming in the ocean, you guys know this, that you go out in the ocean, you're kind of swimming around the ocean on the beach, and then you look up and suddenly you're further away than you thought you were, right? Because the water has dragged you somewhere else. I had this one the last time I was down. I remember this specifically the last time I was down in the Bahamas. Was one of the first times I ever did true, like, deeper free diving. And I'd dive down, I'd look at the coral reefs and stuff like that. And then I'd come up for oxygen, and I'd look, and the boat was, half a football field away. Swim over to the stupid boat, go back down, dive back down, look at the coral reefs, look at the pretty fishies, come back up, the boat's half a football field away. It got to the point that I was thinking that the guys driving that boat were doing it on purpose, but really what it was the drag of the water pulling me places. Yeah, the ocean does make you work, right? It's not all fun and games. It can also be problematic for kids, right? Because, maybe Riley and I can resist the drag of the ocean, but if you put a little 4-year-old kid standing on the shore of the ocean, he can get sucked out to sea really quick. Right? So you have to be aware of that. And then we have the surface tension. Surface tension is that membrane that you have on the top of the water, right? It's that surface being under a specific nice amount of pressure, hydrostatic pressure there, right? And sometimes you can see this if you take a cup and you fill up your cup. Has anyone ever done this where you fill your cup up so far that the fluid kind of rests over the lip, right? There's a surface tension there. And then if you take something and you poke that, right, the water overflows. All water has a surface tension. This is what also causes you to get a sting when you belly flop. Another Mr. McKeever story here. We have a river back in Pennsylvania, which is one of the most challenging rivers to whitewater raft on, which is called the Yahayogini, or the Yak. And about halfway down the whitewater trip of the Yak is this place called Jump Rock. I don't know how high Jump Rock is, but I know that it took me about 25 minutes to get to the top of Jump Rock from the base of the river, You get up there, you look down, you get terrified. I'm not going to jump. Then one of your friends pushes you in. That's kind of the idea of Jump Rock. But I did that. I jumped down in, did a little kind of toes first, right through the water, no problem. It's really deep there. They dropped like 200 feet of anchor at that part of the river and still haven't hit bottom. This other girl jumps off there, and when she jumps off like this. Her arms really wide. Now she has her feet pointing straight down, but she has her arms out like this. And I want to say it was a good about, oh yeah, right. Anna's like, oh no. I want to say it's at least 150 feet down from there. I don't know if it is, but it seemed like it was about 100. This was when I was a kid, so it could be like 25 feet, and I freaked out. But she jumped off like that. Can anyone guess what happened when she hit the water? It split her skin from the middle finger all the way back to her elbow. Yeah, she cried. Literally, the surface tension of the water caused her skin to split. Right, yeah, right. And now, mind you, this part of the river is still another 5-mile float to get to where you can get first aid. So, yeah, not a smart idea, right? That's a hold my beer moment that she probably wishes she had back. So there is that surface tension, right? So be aware of that if you've got somebody, that's why if you see divers, right? When divers dive into the water, they have a very specific purposeful form, right? They're rated on how little splash they create. because if their form is perfect, there's almost no splash, right? They break that surface tension with a knife's edge. And then that's what causes the splash, is surface tension. So just be aware of that. I can also use that surface tension, though, for some desensitization. What if I've got a patient that's got some carpal tunnel sensitization where it's really sensitive? I can have them smack the top of that water. And the harder they smack that water, the more they're affecting that surface tension. And I can get a desensitization out of it. So there are techniques you can use where you can even use that surface tension. Oh, I evidently missed a sentence there on drag. Hey, look at that. All right, some more physical properties of water. Specific heat of water. We talked about this in physics, right? Specific heat is required to raise 1 gram of a substance by 1 degree Celsius. In water, that's 4.186 joules or 1 calorie. That's what everything's based on. Water retains heat 1,000 more times than air. And water is also a faster conductor of temperature, 25 times faster. And the more you move, the faster that heat transfer occurs. How have you all experienced this? How can you know that water transfers heat faster? Have any of you ever gotten in the pool and the pool water's cold, right? You get in, your body adapts to that cool pool water, and then you stand up and it can be 98 degrees outside and the air feels cold. Right? Yeah. And it's a weird phenomenon, isn't it? Like when I was a kid, it was so weird to me, right? I remember having my godsons, we were at a pool, it was like 98 degrees, 99% humidity. And they get out of the pool and they're literally chattering and their lips are blue. Yeah, even 108 degrees, the air is cold. You're like, what is going on? Well, it's because water basically saps the heat out of your body, right? So the water cools you down better in that pool than just the air around you. Also, you have this term called the center of buoyancy. The center of buoyancy is kind of where your center of float is. It's typically about your sternum. It's higher than your center of gravity, which is in your pelvis. This helps us look at how we can reduce body weight in a pool. So we usually say that if you have a patient up to their neck, up to the C7 region or up to the cricoid cartilage, they only have about 10% weight bearing. That means the pool is weight bearing the rest of their weight. If we come down to the xiphoid, so right at the solar plexus, they only have about 33% weight bearing. We come down to the pelvis, right across those ASISs, 50% weight bearing. So just by putting them in deeper and deeper water, we can reduce their weight bearing and make it easier for them to move. The one question that the boards typically ask you about, and I will say just to remember this, is at the neck, the patient only has about 10% weight bearing, so they've had 90% reduction in their body weight. That's a big question they love to ask about on your boards. That little chart over there is really good to remember.
Can you say that again, Mr. McKeever?
Sure, not a problem. So when you put it, let's draw little John here. So here's little John.
I just feel like I didn't get exactly what, like the way you said it. I feel like I didn't get it.
Okay, way. Good. You beat me to it, right? There's little John. Little John's in the pool. If I take him in the water up to his ASISs, so we'll say this is ASIS level here. At the ASIS level, how much weight bearing is he doing? How much weight is going down through his legs? Only what?
50%?
Yeah, 50%. So at that point, like, let's just say that John weighs 100 pounds. His legs only actually have to support 50 pounds. The water's supporting the other 50 pounds. It's dispersing across the whole, that Archimedes Principle type idea. If now I take him a little deeper and now I take him down to his xiphoid, right? So right kind of here down at that solar plexus level. I know this isn't perfect. Sue me for my drawings. At that point, he is only weight bearing about 33%. That means the water is weight bearing 67% for him. That means his body has been reduced by 60%. It's not necessarily 50% of the body parts underwater. It's just based upon the body weight. Good question, John. Because technically 50% would be more closer to my xiphoid process, wouldn't it?
Yeah. Thinking
Yeah.
in body terms.
In body mass type, if you looked at the volume, basically, right? Except for those of us that have chunky legs, and then, well, we throw everything off.
So can the boards either ask us how much the water is weight bearing or how much like the
They may ask you something. So if instead of saying how much the water is weight bearing, what they may say is your patient is submerged up to their ASIS. What percentage of the body weight has been reduced on this patient?
and it would be the 33%.
Well, so let's see. I said ASIS, that would be 50% would be weight reduced, right?
Yes.
If we're at the xiphoid, that would be a 67% weight reduction because the water is bearing 67% of the weight, right? They only have to weight bear 33%. So again, if you weighed 100 pounds, only 33% of your weight, or only 33 pounds is going down through your legs, right? So it feels like you only weigh 30. So basically what it's saying is, if you're in the water up to your waist, you feel like you're only 50% of your normal body weight.
Mm-hmm.
If you're up to your xiphoid, you feel like you're only 33% of your normal body weight. If you're up to your neck, right up here, you feel like you're only 10% of your body weight. So if you want to lose some weight, Brooke, what I'm saying is just go get in the pool and you've automatically lost some weight. See? I should have thought of this earlier. I lose tons of weight that way. Does that make sense though?
It does. I think I would just get confused on if it were asking, like you said, the 67%.
So if it was asking you, so the two questions, the two ways they would ask it is, how much is the patient weight bearing?
Oh, okay.
Right.
So,
If they say the patient weight bearing, that would either be the 50, 33, or 10%.
okay. And
If
will it
it's,
be clear like that?
yes, it will be clear like that. If they say how much is reduced, or what is the weight reduction, then you just subtract the other way out, right? So then you'd have, like if I came over here to this chart, where's my little drawer? There's my little drawer. So if I came over this chart, so I'd have 50%, 67%, 90%. That would be what the water is reducing my weight by. Does that make sense?
Yes, I get it now.
Yeah. So that's typically, again, honestly, most of the questions they ask about that I've seen is the xiphoid, not the xiphoid, the throat. They'll say, up at C7, how much is or they'll say the cricoid cartilage or the voice box or something to that effect. They're talking about the neck at that point. And you're like, oh, well, they're only weight bearing 10%, the pool's weight bearing 90%. You just have to pick which one you need.
Okay.
Does that make sense to everybody?
Yes.
And it makes sense to Brooke, but I just want to make sure it makes sense to everyone else too. John, you good with that? Okay, good. Yeah. I had to add the when I drew little John. All right, temperature regulation. We briefly mentioned this because of the specific heat of water. It's not the same as land. Perception of temperature is different. As the water gets deeper, subcutaneous fat has greater impact. And so it's really easy to either get hypo or hyperthermia, depending upon the temperature of the water. So in your average ordinary pool, you are more likely to get hypothermia, meaning your body is no longer warm enough to sustain life. What type of water might cause hyperthermia?
Like a heated pool?
A heated pool, good, right?
Jacuzzi?
Jacuzzi, good, right? Or the other thing that we have here around town that I wasn't aware of how bad it affects you is hot springs. There was just a story about that I think it was last year, because there's hot springs down off of the railroad trail, if I remember correctly, down towards the Boulder City Dam, or the dam. And there was a patient that got in there and spent a ton of time in the hot spring, and she was older, and she ended up going to hyperthermia. Her body went too hot because, it was 102 degrees outside, plus the water was like 130. Yeah, our body overheated, right? So you got to be aware of that. Cardiac function is affected, and this term called blood shunting. If any of you have ever been in cold temperatures, you have experienced blood shunting before. Does anyone know hyperthermia? That's why a lot of times, if you ever notice on hot tubs, what do they recommend the longest you spend in the hot tub is? Does anyone know? Yeah, 30 minutes. Good. After 30 minutes, it's a chance to develop hyperthermia. Now, Brooke, you may be fine. You may be able to sit in that hot tub, and I've done it where I've sat in a hot tub for like 2 hours and be just perfectly fine. You know, as long as you get up, you cool your body off, maybe get back in, that type of thing, have some water, that type of things. But again, remember that our patients are a little different for this, right? Our patients aren't healthy. So be aware of that if we are working in a warm pool. Does anybody know what the term blood shunting means? Okay, high viscosity. Okay, good, right? That's a peripheral arterial pressure. So blood shunting, has any of you ever gone like up to, I was gonna say Mount Lemmon, but that's down in Tucson. Up to, what's our mountain outside of town here? My God, Charleston. Mount Charleston, or gone up to Bryant Head to go skiing. And you're up there skiing and you take your gloves off and you're like feeling around. And all of a sudden you look at your fingers and your fingers are white. Anyone ever experienced that? Yeah, John's like, yep. That is blood shunting. What that is the body is saying, I need to protect my core. So I don't need my fingers. Yeah, it shunts off to the vital organs. Exactly. What's up, John?
Oh, nothing. I know I had my.
That's okay. I just thought you wanted to say hi to me. That's all. So hi.
What's up?
Yes, it's to keep your core warmer and keep you alive, right? That's why if you ever end up with frostbite, right, what's the first thing to get frostbite? Your extremities, right? Your fingertips, your toe tips, all of that are the first things to get it frostbite because the blood literally gets cut off of them. And so because there's not that nice flow going out to them, you get ice crystals in your skin and you get frostbite, right? So yes, to keep your vital organs warm and your body alive, because you can live without a hand. You can't live without a heart or a brain. So that happens naturally. The opposite. So my mom had hypothermia in the 80s and her. I assume there's more to this. She's typing. Body's still messed up. Yeah, right? Exactly. That's what I was going to get at is whenever you've had a hyper or hypothermic temp incident where it's either gone one way or the other, it does mess up your internal clock and your internal system. This can even come into effect if you've had something like, what's that term that happens here in Vegas when it's really hot out that people can get?
Heat exhaustion or stroke.
Yeah, heat exhaustion or stroke. Yeah, same idea here. That can mess up your internal body temperature for years. So all of that's going to affect. Now, the opposite can happen if you get too warm of temperature, where your blood flow is going to dilate, and you can end up with little bruising and stuff like that if you spend too much time in warm water, right? So remember that normal body temperature is about 98.6, 37 degrees Celsius. So if you were working with a pool, most therapy pools will be between 26 and 35 degrees. What's up, John?
Is there a certain amount of time that, so like let's say we're getting to the dangers of either hypo or hyperthermia, kind of reversing that temperature, is it a certain amount of time though? Is it slowly getting it up there, or?
It'd be better to return it to normal slowly than it is to do the opposite and do the rapid. I know that. I don't know that there's a specific time for it, John. I do know that if, like, say you end up and you have a patient that's hypothermic, you need to warm them up slowly, or if you have somebody that's hyperthermic, you need to cool them down slowly, because you can cause a reverse shock to the system by going either way too fast.
Is it kind of like if you have hypothermia where it's like there would be pain when the reverse happens?
Yeah, typically, even with hyper or hypothermia, the first sign of it returning to a normal temperature is usually pain.
Okay.
Yep.
All right. Thank you.
Yeah, no problem. So 26 to 35 is your normal pool temperature. So again, 37 is normal body temperature. So just about 98 degrees, and then depends upon where you're going down below. That is in Celsius because, again, the rest of the world operates in Celsius, even though we operate in Fahrenheit. So most of the clinics make everything in Celsius. Hold on a second. What does Dr. Reskin say? Okay. So cool temperatures and warm temperatures both will help with relaxing, right? They will help with pain sensation, muscle spasming. If you're going to work in aerobic conditioning, typically you're going to want a little bit of a cooler pool, so 26, 28 degrees, mainly because it helps increase the stroke volume, the amount of blood that the heart is able to pump out, which will then decrease the heart rate, which will decrease the cardiac workload. We're also going to talk about a couple other conditions that we have to worry about pool temps with. So aerobic conditioning, slightly cooler pool. You don't have to know the exact temperature, so don't totally freak out about that. Slightly cooler is an acceptable knowledge. If you're working in a clinic that has pools, you will have to know these. So if you're working with patients and you're going to do therapy with the pool, 20 minutes is typically the max for healthy patients. Why is that? Well, because if I say 20 minutes, you're typically going to do 25. So we know that we kind of shunt off at a certain point so that we don't have patients in for too long. Again, this is not just your average get in the pool, you know, Amanda is going out for a swim and hanging out in the pool with her buddies. This is actual therapy. So working in the pool, 20 minutes is typically the max. So most therapy clinics, when they have a pool, will schedule patients for 30-minute sessions. They'll come in for 20 of those minutes, clean up, tear down, everything like that is the extra 10 minutes. And we do build typically 2 units for those patients. If you have a patient that is more compromised, you may need to reduce that time and be aware of that. You also need to monitor their vitals. They do make little pulse oximeters that you can put on patients' fingers that do work in the pool. Be aware of temps. Patients with RA do better in warm temperature pools. Patients that are spastic do better in cool temperature pools. Patients with MS, multiple sclerosis, typically do better in pools with a lower temperature and will have a decreased tolerance for high temp water. So even if you put them in a higher temperature water, you can actually send them into a flare. So you have to be careful when working with patients with MS. So cool temperatures are better. So then that begs this question, you know, like pools in the community. Pools that are like at the Jewish Community Center, pools that are more geared towards older folk getting in the pool, those typically are warmer pools. Pools that people swim laps in, stuff like that, those are typically cooler pools because, again, work on the cardiac workload, right? Traditional pools are usually between 100 by 25 feet. That's your average therapy pool, but they can be as small as 10 by 10 or 10 by 25. Can be anywhere from 3 to 10 feet deep. And again, the deeper the water goes, the more we're going to work on floating techniques and stuff like that. We typically don't work in 10-foot deep water. You know, most of the therapy pools I've been in, like 4.5 feet, 5 feet is about the max. So, you know, some of you may still be underwater at that height, but most of you aren't underwater at that point. You're usually okay. We can also do therapy in individual patient pools. I've done that in home health where I've gone and seen a patient and they have a pool out back and we'll go out to their pool and we'll do therapy out in their pool. You can do therapy if they live in like an apartment complex. An apartment complex has a pool. Like I said, I see quite a few of my patients usually over at the Hollywood pool, or not recently, but I did when I was seeing patients over at the Hollywood pool over on the east side of the valley out in the middle of nowhere. If you don't know where the Hollywood pool is, go to the mountains. You found the pool. So what kind of care and safety do we have to worry about? Well, in the pool, the big virus or the bacteria that can get you is Pseudomonas aeruginosa. right? This is a common bacteria present in warm water pools and especially hot tubs. It's also known as hot tub fungus, even though it's not a fungus, right? It has an extremely rapid transmission and infection rates and has a high antibiotic adaptation rate. What that means is easy to transmit, easy to get, hard to treat, because it can, your doctor gives you an antibiotic, it can adapt to the antibiotic pretty quick and become antibiotic resistant. That's why it's really important to clean pools regularly, right? And pH test them. Typically, the rules of thumb for physical therapy are the pools must be cleaned at least 2 times weekly, and the levels in the pool must be checked twice daily. Typically, when we do that, it's usually in the morning, and then at lunch, the pools get checked. State laws may dictate more. I know in Maryland, they are required to check 3 times daily. Okay, so we check it 3 times daily. Walking surface around the pool should be a rougher material, typically rubberized, with adequate drainage. You don't want anywhere there is pooling of water, right? And also, I know that we've all seen this when we were growing up, and we've always heard the lifeguards say no running at the pools. Yeah, even at therapy pools, there's no running around the pools. Some safety and regulation guidelines, life preservers. If you have people in the pool, there must be at least 1 life preserver for every patient in the pool. So that means if I know that I'm going to have a therapy class of 10 people in the pool, how many life preservers must I have? So I have 10 patients. 11. Why, Jason?
Because you got to count yourself.
Yes, good. Right? So you have to make sure you have 1 for every person in that pool. Right? Children must be wearing an adaptive flotation device approved typically by the U.S. Coast Guard while in the pool, even with therapists. So if Jason's working with, a little 12-year-old Jimmy, he typically has to have a flotation device on. And those little arm floaties aren't always enough. Always be thinking that your kid can drown. You don't want your kid to drown. At least 1 member of the therapy team needs to be pool CPR certified and trained and must be on site during pool usage. So let's say that Mara is our CPR certified pool therapist and she's taking PTO. She's going out and she's going to go up to Mount Charleston hiking for a day. Can we still use the pool if she's the only one? No. If she's on PTO for that day, there's no pool therapy for that day. Or we're going to have to train Jason or John on CPR for the pool, because CPR for the pool is different than your CPR for land. Now, if you've gone through lifeguard school, you've probably had CPR for the pool. So I understand. I don't know. I've never gone through lifeguard school. So you probably have that license. If that's something you've done, I would highly recommend keeping that CPR for the pool or aquatic CPR active, because that can make you a lot more marketable once you graduate and get licensed, that you have your aquatic CPR certifications. See all the ways you can make yourself a little bit more marketable. What type of equipment can we use in therapy? Collars, rings, belts, vests, swim bars, gloves, hand paddles, or these things called hydrotone bells, which are basically like dumbbells that the water tension themselves increases their weight. Fins, hydrotone boots that weigh you down more, kickboards, pool noodles. But the key thing here is don't overlook the dollar store. So I'm going to be honest. I bought a lot of my pool equipment for working with kids from the dollar store, all of these kinds of pool noodles, kickboards, stuff like that, that if they break, I'm not too sad about losing them. Right? So just be aware it's an easy way to get inexpensive use that can be used equipment that can be used repetitively. This is something we usually miss out on. All equipment needs to be sanitized between patients, just like any other therapy equipment. Why do you think people don't sanitize the pool equipment? What do they think?
That it's already getting sanitized in the water.
Yeah. Well, it's already in the water, right? You still need to wipe it down. And that's the other thing, Riley's like, go to the road. That's life, right? You've got to make sure that you're cleaning the pool equipment when you're getting in and out of the pool. And honestly, it just takes wiping it down really quick. The Clorox will take care of most of the stuff on it. Just be safe rather than sorry. There's different equipment for deep water versus mid-water equipment. There's flotation belts, there's vests, there's flotation dumbbells, noodles, we'll talk about fins, special design boots, all that fun stuff. Any of these work out well, but here's the deal, is you don't really need to have any special equipment to do pool therapy. I can do pool therapy without ever having a single piece of equipment, as long as I'm safe with my patient and I do what the patient needs. So this is just kind of looking at some of the basic exercises we can do in the gym, or in the pool. So the first one's just doing internal external rotation with a little mitt or a paddle board in the way, flexion extension of the elbows, you know, almost a straight leg raise. You can do squats in the pool. You can do heel raises in the pool. We've got other ones over here, which aquatic workout. I got this out of the aquatic book that I have, and also from militaryspot.com. I have no idea what that is. But that came out of the book that we have for aquatic therapy. You do side leg raises, leg overs, all this kind of stuff for basic therapy. But this is talking about here is showing is that I mentioned that we have 3D access to the patient. It's really easy for me to stretch a patient's neck when they're floating in the pool, because when they're floating in the pool, they're typically relaxed. And I can either move the head, or I can move the body, or I can move both. And that gives me a greater range of motion with patients. In the second one here, I'm doing kind of lateral flexion of the trunk, where I'm pulling their legs around me and their arm around me to create a force that's kind of pushing that lateral aspect of the trunk outwards. Here I'm working on the shoulder, where I can do shoulder flexion in the pool, right? I can do shoulder flexion outside the water while the body is floating and relaxing. I'm doing PNF over here. Look, up and out, down and in. So pretty much anything you can do on land, you can do in the pool safely. You can even do massage in the pool. I really like doing my suboccipital release in the pool. So I put a patient in a floaty like this patient has over here around his waist. And I get on the back of their head and I kind of let the water pull them and push them away from me, that laminar flow of the water. And I can get a really nice suboccipital release on that patient. And it really does help with that three-dimensional aspect of accessing the patient. All right, that's it for aquatic therapy. I'm going to pause the recording here. All right, and we're back from break, and we're ringing the bell. Oh, no, wait, no, that's sorry. We're going to talk about spinal therapy now. We're going to start with some kind of terms, thoughts to know. We're going to do a really super fast anatomy thing, and then get right into kind of talking about some stuff. So when we're talking about spinal therapy, a lot of some of the terms that we talk a lot about when we're dealing with the spine, the neck, the upper back, is these terms of tightness, stretch, overstretch, and contracture, right? So tightness, we've all had. Tightness is just the muscle's tight, it doesn't want to stretch as far as it can, right? We all get tight. We probably all have quite tight quads. We probably all have tight low backs, right? To counter a tightness, we stretch. But we've got to make sure that we stretch to a point of a stretch, not to the point of overstretch. And when we talk about overstretch, at that point, we are stretching a muscle beyond its exceeding tissue excursion. That's where you can end up with injury. And that takes clinical skill, because to go from just a nice tight stretch to an overstretch and injury for certain muscles is really easy. For the neck, it's a really easy thing to do, to go from a nice stretch to I'm not paying attention and I overstretch my patient. Right? So when I'm stretching my patient's neck, that is not a time I'm talking to the other clinicians in the clinic, right? Because the neck muscles are kind of tiny, and it's not going to take a lot of torque of me pulling down on their head to tear a muscle. I've got to be focused on paying attention to what my patient says, what I'm seeing from the muscle, what I'm feeling from the muscle, what I'm hearing through my hands, right? And we're going to talk a lot about that when we practice both stretching and the manual therapy is you need to become really good listeners with your hands. And that seems like what's the term I want to use? That seems like a stupid term to say, right? I need to listen with my hands. What do you think I mean when I say you need to listen with your hands? Anyone have an idea? Go ahead, Riley.
Be able to like feel where the resistance is.
Yeah. Or feel when, like, if I'm stretching Riley out and stretching her neck and she starts guarding, right? She's like, oh no, that's enough, Mr. McKeever, right? I've got to be able to feel that. Amanda, what do you think?
Yeah, I was just going to add on that also, just to be able to like negate all other noise, like even with your eyes, your ears, like things that we normally use.
Yeah. Very good, right? And you'll find when I'm doing a lot of my manual therapy, I have my eyes closed. A lot of, I mean, I can go from Joe's toes all the way up to his head and avoid all the areas I shouldn't touch on Joe just by knowing where my body landmarks are. But I can learn so much by listening to what my hands tell me versus what my eyes see. I can find, oh, he had a previous tear here on this muscle because it feels kind of jagged and rugged. Or, ooh, there's a trigger point right there. I can't physically see them, but I can see them and hear them with my hands. And so it really gets beneficial. And it's amazing, like, because I've talked to a bunch of massage therapists, and a lot of the really good massage therapists I've talked to, when they're doing therapy, they either close their eyes when they're doing massage therapy, or they tone out their eyes. And when I say tone out their eyes are open, but it's almost like you're a heavy-lidded sleep open, where you're kind of just moving through the motions with your hands and your eyes are just kind of partially open enough to make sure you're not touching something you don't want to touch. Because sometimes that happens. And so listening with your hands is really big, especially when you're stretching, right? You can feel when somebody starts getting spastic and you're like, okay, that's a little much, right? Okay, back off. Okay, that feels like a good stretch. If we don't fix a tightness, it can develop into a contracture. And a contracture is where that muscle becomes an adaptive shortening. It starts shrinking, literally, right? Could also be the connective tissue around it. It could be the tendon. It could be the muscle belly itself. And it can be irreversible. It's not always, but it can be irreversible, meaning that if we don't, yes, absolutely, John. Overstretch, there's a good way to put you're getting dissociative. Good job, right? It would be going past that myotatic reflex, definitely. And, if you're resisting my stretch, you theoretically could keep me from going into myotatic reflex, right? You could use enough force to overcome it. And that would be bad because that's probably going to tear my muscle, right? But if I get that contracture, it could be irreversible. So we've got to be paying attention to it. Or it could be irreversible in therapy, right? Where maybe therapy is just not going to do it and they have to have surgery. So what happens when we have mechanical stress on muscles and with their strength and endurance, right? Poor activation of postural muscles allows the body to kind of collapse down on itself. And when that happens, we exaggerate our spinal curves, right? And then the muscles themselves lose the ability to know what proper posture is. And then when you correct somebody if you get somebody that kind of sits like this constantly, and then you correct their posture, oftentimes they're like, that doesn't feel good, or that feels wrong, or, it's really hard to hold myself up like this. Well, it's not because they're silly or they're stupid, or it's not because they can't. It's because the muscles have lost the ability to sit like that for long periods of time. And so we've got to kind of reawake those muscles. When muscles are overstretched for long periods of time, they may acquire this term stretch weakness. And that's where that muscle has been lengthened for so long, it loses the ability to contract as hard as it used to. So that means lengthened muscles may become weak, tight muscles may contract, right? But even at that tightened form or that contracted form, they're still going to be slightly weak because they don't have the ability to expand and contract as much as possible. So that means that even if I'm stretching out the bicep because I know it's tight, it might not also be a good idea to strengthen the bicep as well. So we're always going to be doing a nice blend of stretching and strengthening. When the muscles themselves no longer are able to hold our load, all of the other tissue starts supporting our load. All of our ligaments, connective tissue, skin, bones. So when we start doing kind of bad posture, we start relying on associative structures versus our muscles to hold us upright. And that only exacerbates the problem and causes posture to get worse. If we're not breathing right, we don't have good abdominothoracic motion, right? That can lead to poor posture as well. Because we know that the rib cage expands with inspiration and relaxes with exhalation or expiration. The thoracic spine tends to go into extension with inspiration. But then we have this term Valsalva. Have you guys heard that term before?
Yes.
Okay. When I think Valsalva, I think of one thing and one thing pretty much only. And it's my way of thinking of Valsalva. What do you guys think of when you think of Valsalva?
Weightlifters.
Okay, weightlifters, okay. Good, they do Valsalva a lot, you're right. I think of Valsalva as the pooping maneuver. Right, you're trying to squeeze out and you're constipated. Right, you're bearing down really hard. That is a Valsalva maneuver. When you do that Valsalva, it increases that abdominal or inner thoracic pressure, right? And it creates an air bladder, right? That can raise blood pressure, right? And can actually cause all kinds of problems with your body. And it can decrease the strength of your pelvic floor. There's all kinds of things that holding your breath and doing that Valsalva maneuver can cause negatively. On top of, you're not breathing, right? So holding your breath is problematic of it. It also can weaken that TVA or the transversus abdominis. I tend to call it TRA, transversus abdominis, but TVA, TRA are the same terms, just to let you know, as transversus abdominis. And that's where we kind of use that to hold our belly tight versus Valsalva where we're bearing down. So Valsalva, bad. And it can pop a blood vessel in your eye, absolutely. And you can actually have a stroke from a Valsalva maneuver. I have actually seen patients do that where they came in for a stroke, they go in to go to the bathroom and have a stroke in the bathroom because they're squeezing out something so hard, you know, it's kind of like you're creating diamonds back there. So you want to make sure you're breathing. Even when you're pooping, you're breathing. Even when you're peeing, you're breathing. And honestly, think about this the next time you do go to the bathroom, right? Doo-doo. Or you go pee, right? Think about it. Think if you're actually breathing while you're doing it. Because I'd be willing to bet some of you don't. And you probably do Valsalva. And maybe try breathing a little bit more, it might work out easier. So the term of peripheralization versus centralization we talked about, right? Peripheralization, bad. Centralization, good. Peripheralization is where we begin with problem that occurred at the spine and is now radiated outward, whether it's down one leg, if it's in the neck, it radiates down the arm, right? Or sometimes it can even radiate up into the back of the head, and you can get what's called a cervicogenic headache. Does anyone know that they get those type of headaches? When their neck gets tight, they start getting a headache? Okay, Stephanie says, yeah, right? Yeah, cervicogenic headaches are really kind of painful. My life, exactly. Right? So peripheralization is bad. Bringing it back to the center, back to the spine, good, right? Which is why we usually tell a patient, please understand, as we work with these techniques, your back pain may get worse. That's okay. I understand it. I could help that back pain get better if it gets worse. but we got to get it back to where the pain should be and not out at your big toe. So peripheralization, bad, right? Centralization, good. And I had the question before, is peripheralization kind of like referred pain? It kind of is. Again, referred pain is typically more organ related, but yeah, I mean, peripheralization kind of is referred pain. It's pain that's located somewhere distal to where the actual problem is, right? Your problem is at L4, but you're feeling it in your knee. That's just your body's way of saying you didn't pay enough attention to me when you actually injured it. So quick anatomy review, right? We have our spinal column. We have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 3 or 4 coccygeal bones. Uh-oh, I heard a voice. What's up, John?
So when you're, so like let's say when a patient is feeling like tingling towards their fingers, is that also considered like peripheralization?
It can be, unless it's something where it's like carpal tunnel related, right? If if the problem is in their carpal tunnel, that's not peripheralization. I mean, technically, I mean, really, it is peripheralization from where it is.
Yeah.
That would be
even like towards like the legs or anything like that. So it could just be like lumbar or anything.
yeah. If it's originating from the lumbar region and it's going down the legs, that is peripheralization. Yes.
Okay.
But now that you made me think about it, I mean, even if you have carpal tunnel syndrome, you know, your problem is your compressed median nerve and your fingers out here are going numb. That's technically peripheralization. So, I mean, and once we start working that, oftentimes that carpal tunnel gets more sore as we get better. And that would be centralization. So, I mean, even that occurs there. I didn't really think about it, but yeah.
Okay, that sounds good. Thank you.
Yeah, I didn't think about it. You guys make me think about stuff I don't think about. See? All right. So one thing to know about the spine and remember is that although we only have 7 cervical vertebrae, we have how many pairs of cervical nerves?
8.
8, yeah. So don't let your boards catch you. If they ask you how many pairs, it'd be 8, right? If they ask you how many cervical nerves are there, how many cervical nerves are there?
16.
16, yes. Right, because there's 2 on each side. Or well, there's 1 on each side, so I meant. So you have 8 pairs times 2. So don't get caught by that, right? If they say, well, how many thoracic nerves are there? There'd be 24. So don't let yourself get caught. Make sure to read, are they talking about pairs? Or are they talking about just the nerve roots themselves? And typically they don't ask you about sacral or coccygeal nerve roots, so don't worry too much about that. When we get down to the actual spine itself, we talk about 2 main parts of it. We talk about the anterior pillar, which is mainly the body, the discs, and the weight-bearing portion. And then we talk about the posterior pillar, which is everything else in the back side, which is where a lot of the spinal cord passes through, all those foramen, all the articular process, all the facet joints, everything like that. Spine has a couple different motions, right? It's flexion extension, side bending, rotation. It does have some anterior and posterior shear to it. It has some side-to-side shear, and it can be compressed or distracted. So there's all kinds of motion that can occur at the spine. And then we get down to those wonderful disces, right? You have the annulus fibrosus, the jelly, and we have the annulus fibrosus, the donut, the nucleus pulposus, the jelly, right? And I love the mucopolysaccharide gel. That doesn't tell me anything. It's a jelly. Just call it jelly. There are cartilaginous end plates out there with it as well. The one thing to know about your discs is they are largely avascular and aneural. So if a patient is to have a herniation of the discs, are they going to have pain from the herniation itself? No. Good. Right? So don't let a patient kind of snowball you with that. Because most of the discs themselves, right, it's from compressing the spinal cord or the nerve roots, right? Most of the disc itself has no nerves. So if it slides right or left, it doesn't care. What it compresses cares, right? That also means that if I should tear a disc, it's not going to heal very well because it doesn't have a good vascular supply, right? So it doesn't regenerate as well. And then also, as we get older, our discs just break down. Like, it just happens. As we get older and we weight bear them for years and years and years, they just break down, right? I would be really curious, and again, this is one of those kind of good old gravity here. This is one of those things that I'd be really curious about is in, 20 years from now, if we take a look at somebody that worked in the 50s and looked at their, like we had a pretty preserved spinal cord and looked at somebody that lived through this time period to see the changes in the spine. Again, one of my favorite TV shows of all times, to be 100% honest, and I don't know if any of you ever watch it, is called The Expanse. Has anyone ever seen that show? It's also great books. I've read all the books. Anyone watch that show? Am I the only? Okay, so Amanda watched it. It's a great sci-fi show. And one of the things I find interesting about that, the book series and then also the TV series, and I highly recommend it if you get a chance to watch it, is there are people that still live on Earth, then there are people that live in the asteroid belt, and there are people that live on Mars. And the people that live on the asteroid belt, where they live in 0G, are all taller and lankier than the people that live on Earth. Well, why is that? Well, because their discs have had the chance to just constantly expand, right? Their bones are lighter. They don't have as much weight bearing. It's really interesting the way they did that show, that, and the books themselves. They actually had astrophysicists help write some of the books and stuff like that, which is really cool. But I know it's kind of geeking out about sci-fi, but that would be literally what would happen. If we ever get to being a spacefaring race where we go out and, space the final frontier like Star Trek and that, if we aren't able to create artificial gravity on those ships, the humans that would come back from those trips would look totally different than the humans that left. So like, say we had a generational ship where, we send off 60 families to explore some planet far away, and then they're eventually going to return. The people that would return would look vastly different living in space than the humans that lived on Earth. It's kind of interesting. And actually, if you ever watch any of those ancient alien shows, we kind of look like the gray aliens, but that's beside the point. We're not gonna do anything. It does make our bones brittle and weak, for sure. Yeah, on the twin astronauts, exactly. Yep. It's kind of unique to see how it works. Yep, you guys must be twins here. But yeah, I mean, it would make our bones brittle and weak, right? And so we'd have to find some other way to weight bear, right? We'd have to do something like magnetic boots to pull us down so we're forced to weight bear or something to that effect, for sure, Anthony. But again, that's why I said we'd look totally different, right? And like, to the point that our faces would be elongated, it would look really weird. I'm just saying. And that TV show, I think Amanda said she watched it. And if you've watched it, Amanda, you saw the way they made the people look different that lived on the belt, right? Their spines were different. They had to get spinal injections. It's actually kind of interesting. So for stability in the lumbar spine, our abdominal muscles are key. So transversus abdominis, one of our key things, our erector spinae as well. Then our multifidus, which works along with our TRA, and our thoracolumbar and thoracodorsal fascia. That all helps keep our core nice and tight and stable. So that keeps the lower portion stable. What keeps us stable up here? Well, the mandibular elevator group, so the group that helps elevate our mandible, helps us. The suprahyoid and infrahyoid muscle group, because you guys remember all those muscles, right? The omohyoid, the myohyoid, you guys learned all those, right?
No.
No, you don't have to know them, don't worry. I just want to make you paranoid. That's all. So if you would ever get a question about these, yeah, cruel and unusual, I love it. if you would ever get a question about this, it would just be talking about the muscles that are in control of the anterior surface of the spine. If you saw something about a suprahyoid muscle group, you would know that it would be muscles above the hyoid. Right? So that would be the upper portion of the platysma, versus infrahyoid would be below the hyoid bones, the lower part of the platysma and some of those scalenes, right? We also have those rectus capitis, lateralis, longus coli, and longus capitis that we talked about in kines. Again, that you don't have to know their specific names, but they kind of keep us back in retraction and nice extension. And then we do have the multifidi up there in the spine again that helps stabilize that. The interesting part about all of our muscles in our neck and our back is they tend towards being more oxidative muscles, meaning they are a long-term endurance-based muscle. And that kind of makes sense, because if they were a power muscle, they would basically help us stand up, and that would be all they do, right? The muscles of our back are designed to be kind of turned on and turned off as we need them as we're moving around, right? If I lean to one side and then go to the other, different muscles fire and may have to hold for different periods of time. So even with that, with all the muscle control, we also have neurological control of stability. Does anyone know what tract is responsible for balance? What spinal cord tract is responsible for balance in the human body? Way back when you talked about the spinal cord tracts in anatomy.
Were you asking for like ascending and descending tract?
Okay, well, yeah, but the specific name of it. Well, what is our balance system? First of all, let's go there.
Cerebellum.
Okay, cerebellum. Okay, that's getting a little more close. What is our main balance system in our ears?
Vestibular.
Vestibular. Good. And if we know that the spine controls our balance, and we have a tract going from the vestibular system to the spine, what do you think that tract is called? Remember we talked about spinocerebellar, all those fun tracts in anatomy he briefly talked about, the ascending and descending tracts. Close, the other way around, Riley. Vestibulospinal, there we go. Right, because the vestibular system is going to feed information to our spine. Now, I'm going to add a kind of caveat to that, because there are some fibers that go from the spine back up to the vestibular system too, but primarily we call it the vestibulospinal system. It's a tract that descends from your vestibular system and sends signals down your spine to control your posture, right? As your ear feels you leaning to one side, it sends a signal down saying, straighten up, dummy, right? So we have this ability to have that feed forward control for spinal cord stability, right? As we detect things changing, we make changes. Focus camera. There we go. I've got my replacement camera coming, so I'm so happy. When our limbs are moving, whether we're walking, whether we're doing exercise, right? So Anthony's at the gym and he's doing, you know, the beautiful shoulder extension activities, right? That's going to affect his spinal stability. As he brings up that one weight, his spine has to compensate and go, okay, so I've got weight out here. It's putting me, kind of pulling me that way. I've got to pull this way and a little bit laterally in order to keep me perfectly in balance so I can go on to the next exercise. So any type of movement will do that, but eventually you can end up with localized muscle fatigue from doing those things, right? And maybe you just get tired and you just don't have good balance anymore. Or you can end up with a muscle imbalance where one muscle is stronger than the other, or should be than it should be, right? But all of those can have effects on posture, breathing, and stability, and then can lead to stuff like increased abdominal pressure, and then increased reliance on the Valsalva maneuver to do simple things, right? If I don't have good core strength, in order to stand up, what I do is I do that Valsalva maneuver to push air back into my spine to straighten my spine out as I stand up, right? Versus if I have good core strength, I can just kind of use my core and I can talk when I stand up. But if you don't have that good core strength, you're going to use other techniques for getting around it. So we have posture deficits, right? We talked a little bit about posture in kinese and talked about the different things we look for. We can either have a frontal plane deviation, or a sagittal plane deviation of the spine. A frontal plane deviation, side to side, is a scoliotic curve. That's a lateral curvature of the cervical, thoracic, lumbar, or all three. Because theoretically, you could have curves the whole way down your back. It could be a structural problem. Structural meaning that the problem actually is occurring with the bones themselves. Or it could be non-structural, where it's either muscular, skeletal, or a combination of both, or posture related. So let's say, I'm going to use this as an example because I know that we're going to get questions on this on the boards. So I've only got one curve. So we're going to call this the left, and we're going to call this the right. So your boards tell you that your patient has a right primary curve. So that just means they have one curve, and it's going to the right. So there's my right muscles. Here's my left muscles along my spine. The boards are always going to ask you which muscles are stretched and which muscles are tight. Okay, right side are stretched. Good. Why?
It's getting pushed.
Yes, they're being pushed laterally. Good. Right? You've got a longer curve going out that way, so they are stretched. So my right side are stretched. That means my left side are tight. Right? Because they're kind of getting squished up in that curve. So if that's the case, if my right side is stretched, how do I fix that? What do I do to it?
Go the opposite direction.
Good, I go the opposite direction, right? You're exactly right. So I strengthen my stretch ones. Why can't I spell strengthen today? There we go. I'm going off somebody else. And then my tight ones, I'm going to stretch. Yeah, right? So Brooke had it right along the way. I'm going to go the opposite direction. Good. All right, so I'm going to stretch out those tight ones, strengthen the weak ones. Now, I may still strengthen a little bit of those stretched out ones just because, or those tight ones, just because maybe they're a little weak as well from being shortened for so long period of time. So it's not a bad idea to strengthen both sides a little bit. But our primary one we're going to strengthen is that stretched side. Now, that's if we have a non-structural scoliotic curve, meaning that it's primarily posture or a musculoskeletal issue. If it is a true structural where there's a problem with the bones themselves are screwed up. So maybe you're looking at the vertebral bodies and the vertebral bodies look like this. So one side is kind of coned. There's not much us as physical therapy is going to be able to do to help that. Right? If it's a bony problem, they're going to have to see somebody that specializes in bony problems, typically a spine surgeon or somebody like that. I mean, we can help a little bit by stretching the weak side or stretching the tight side and strengthening the weak side, but we can't fix the bones being screwed up. Right? So we typically work on non-structural patients when we're talking about scoliotic curves. So if that is a frontal plane deviation, then when we have a sagittal plane deviation, we'll either have a kyphotic curve or a lordotic curve. And we have natural occurring kyphosis and lordosis going down through our spine, right? We have a little bit of cervical lordosis, kyphosis in the thoracic, lordosis down in the spine, kyphosis lower down in the pelvis. So that front back motion, right? In kyphosis, we can have a congenital or postural kyphotic curve, where we get that posture where it's occurring where it shouldn't be, or it's exaggerated, right? Think of somebody that might have something like Parkinson's. They typically have a really exaggerated kyphotic curve in their upper back from posture, right? And when I think of kyphosis, I think a lot of like the Hunchback from Notre Dame and stuff like that. Osteoporosis can also create a kyphotic curve, right? They can also end up with a condition, I think I've got it mentioned later on in this lecture, which is called Sherman's disease. I'm probably going to butcher the spelling, but I know I have it later in the lecture. Which is a condition of kyphosis where the patients develop these things called Schmorl nodes. That's not spelled right. I know this all sounds made up and it sounds like Mr. McKeever's just throwing words out there, but it's not. The main thing you have to know about this is for your Sherman's disease. I spelled it pretty close. Hey, I'm pretty close. Give me some credit. Right? But what happens here is if we're looking at a lateral aspect of the spine, so here's my vertebral bodies, right? When I get a Schmorl node, part of my vertebral body, let me draw it a little differently, kind of becomes deformed. Or I get something else like a blood vessel or something to that effect replacing it. That decreases my stability. And then because that, this bone shifts backwards, and that's going to create a kyphotic curve on me. So it can also be from problems with the bones themselves, right? Lordosis can also occur, and we can actually end up with hyperlordosis, where we end up with too much lordosis. I would argue that really too much lordosis isn't as big of a problem as not enough, right? Because when we have that flat back, we tend to lift with our back, and that's not a good idea. But kyphosis is bigger of a problem than lordosis. Lordosis just kind of occurs naturally at our low back, right, when we do those pelvic tilts. No matter if I've got a scoliotic curve, a kyphotic, lordotic curve, the main idea when working with a patient is making them aware of their spinal posture, right? And that can involve verbal cueing. All right, Mr. McKeever, you're slouching again. Sit up good and straight, right? Or maybe my verbal cueing is not working, so now you get tactile with me. Come on, sit up good and straight. Straighten that neck out. Good, pull that chin back. All right, good. And then visual cueing. You could even do something like I'm doing right now where I have the webcam on, right? So maybe you don't have a mirror handy, right? So maybe you're in a clinic, they don't have a ton of mirrors, or maybe the mirror is being used. You've got a mirror right here. Just turn on your good old camera, right? All right, I'm gonna bring my camera up. I'm gonna flip it and invert it. And now I can put that right in front of the patient, right? So I can put my camera right in front of my patient and use that as a camera or mirror for them to follow and look at themselves and go, oh, okay, gotta straighten myself up. Gotta look good for the camera. Right, gotta pretty myself up, make sure I'm all good. Get rid of these gray hairs. So working on that axial extension, right? Keeping the cervical retraction there, keep that forward head posture out, pull our scapulas back, sit up nice and tall. And what's funny is just try this once on yourself once. If I'm kind of lean forward and then retract your head back, pull yourself back into cervical retraction. and feel what happens to your whole body. You kind of end up going up in a nice, neat posture just by retracting your neck back. It's amazing how much doing something like a chin tuck tends to straighten your whole back out. And then I can work on a chin tuck with some scapular retraction, getting my back good and back, right? And then making sure my pelvic tilt's neutral. I have good pelvic tilt, right? Okay, chin tuck, shoulders back, good pelvic tilt. All right, there. Now thoracic spine, make sure I'm not twisted one side or leaning one side or the other, nice and straight up. And then I can just combine all of that into all of my motions so that I'm not even thinking about that anymore. And now I'm physically, literally just doing the motions as a total spine motion. What affects our posture and causes deficits? Well, body mechanics, right? And I'm as guilty of this as anyone else. Right? I was thinking about that this weekend when I was, forget where I was exactly, but I broke my laptop out and was going to play a little bit of Dark Alliance this weekend. Broke my laptop out, got my controller out, and as soon as I got that controller out, I kind of sat down like this. And I'm like, crap. Back up, nice and tall, right? Ended up getting out one of the big physio balls and sitting on the physio ball to actually play video games. And it was a totally different experience. If you have one of those and you are a gamer, try it once. It's a totally different experience. It's definitely more core control that you have to focus on while you're playing a video game. And like I said, one of the things we're probably going to do when we go back is a little bit of fun messing with balance with you guys. Ergonomics is big, right? Making sure that all of my stuff is exactly where I need it, that I don't have one monitor where I'm like this, right? I've got my TV overhead, but I don't really use that for what I'm working on. That's just usually my TV that's got CNN on to make my blood pressure to go up. All of you guys are right here in front of me, so everything's at eye level. Keyboard, my wrists are in neutral, right? That helps me maintain my posture upright. A good chair, all the proper equipment. I've got a nice wrist rest here for my wrist when I'm here. That helps me maintain hands, which then doesn't translate up my shoulder and cause me to lean. So there are all kinds of things you can do ergonomically to make sure that you're using a thing. Better for me would be to have a stand-up desk. I don't have one of those. My desk is ancient and is made of oak, so there's no way it's standing up. But having a stand-up desk is really good for that, for keeping your back and your body nice and healthy. On top of that, stress management and relaxation techniques. We just did a stress anxiety course with the students getting ready to take the board exams. And one of the things we worked on was conscious muscle relaxation of the cervical region and of the whole body. And then doing techniques to just relax. And it was amazing how many of them, after they did this class, they sat there and they're like, I don't want to get up. I just feel so good right now. My body is just so relaxed. I could go curl up in the corner of the classroom and take a nap. Because for once in their life, their bodies have relaxed. And I'm sure some of you have experienced that at some point where you finally get to that point where you're relaxed, you're not worrying about stuff. And the next thing you know, out you go, right? Because your body finally says, I need to shut down for a little bit of time. Heat and massage can be really good, but also healthy eating. Healthy eating does help our spine, especially getting the right amount of calcium and vitamin D. So we talked briefly about the pathology the other day of the discs, right? Where the discs break down. We can end up with herniation, which is where the disc material is kind of moving beyond its normal limits of its space. We can end up with a protrusion, which is a type of herniation where the disc material remains in the disc, but it's moving around in that annulus fibrosus. Then the worse than a protrusion is where we get an extrusion. Now disc material is actually moving beyond the ligaments, right, or the intervertebral space. So that nucleus pulposus is starting to get outside the jelly, starting to escape the donut. And then the worst is the sequestration, where the jelly has shot out of the donut. At that point, there's not much we can do for it. This can happen over time, or it can be traumatic, meaning it can be a fatigue breakdown where we've had bad posture for a long period of time, and that causes it. Or in the case of me, that I ended up with a protrusion of my spinal disc, I was working with a stroke patient who backhanded me. And when he backhanded me, I went backwards over the parallel bars. And that caused my L4 to actually protrude. So you can have a fatigue breakdown where it's just time, or a traumatic breakdown where you can end up with these problems. You can also end up with it because of axial overload, meaning you've got too much weight pulling down on you. I think a lot of that when I think of the military, right? When they make us run with 85-pound rucksacks. All that's doing is squeezing those discs and leading to protrusions and herniations. And honestly, a lot of the patients I saw back in Pennsylvania, because we had 3 bases around us, a lot of those patients that were in the military, the reason we saw them was low back pain. Well, it's wearing boots 24/7, and then also, not exactly the best body mechanics. And then as we get older, we degenerate, meaning that, can you still hear me, Anthony? Did I lose anybody, or just Anthony got lost?
Yeah,
Okay, cool. Okay, Anthony's just got lost. That's okay. It's recorded, Anthony. You know it always is. We won't blame you this time. So as we age, just think of this for a second. Let's talk somebody who's 17 and 17-year-old male. I'm just going to use male as an example. I am not being sexist here, ladies. I'm just using this as an example. Please don't think I'm being sexist here. Played football, Pee Wee football, Pop Warner football, all the way up through high school. Graduates high school and decides he's going to become a Marine. So he goes down to Parris Island, goes through basic, and then, becomes an infantryman. So, more running, carrying all these bags, doing this stuff, decides to make a career out of the military. So at that point, he's, doing this for the rest of his life and just beating up his body over that whole period of time. This can happen to ladies as well. I've known plenty of female military members that have had same problems here, right? And then you add to that the hormonal difference between men and women, and that can make things even worse. As you get older, then you've just opened yourself up to more and more problems, right? And it's not like the places that the military goes are exactly conducive to good body mechanics, right? If you're in the Navy or in the Marines and you're walking around a carrier or any of the ships, you're walking around on steel all day long. That's not exactly conducive to your low back. Could be out in the desert. Again, not conducive to your low back. So all that's going to affect your spinal mechanics. And as you get older and older, that spine is going to break down more and more. And they're going to see us more and more. So as that fluid, the tissue fluid, the stasis of the fluid should stay contained, right, in that disc. But as it shifts around, that's going to cause all kinds of problems. So what happens when that fluid kind of escapes the disc? Well, it can put pressure on the spinal nerves. It can put pressure on the spinal cord itself. Typical symptoms they're going to have is pain. They're going to have neurological symptoms, so burning, tingling. The symptoms are going to vary. They're going to say, Amanda, when I wake up in the morning, I feel really good. But at 5 o'clock when I'm getting ready to get off work, man, that burning and tingling is getting worse in my legs. Okay, that's a breadcrumb. Well, what are you doing all day? Well, I'm standing on my legs all day and I'm moving boxes around. Pressure squeezing down on those discs, right? Moving that disc laterally or anteriorly, right? Posteriorly. Or they'll say, when I lean like this, my symptoms get better. But when I go back to here, they get worse. Symptoms are shifting. Give us an idea. It's a little breadcrumb to follow. And I'll be like, yeah, my back is just always really warm. Inflammation. So that's where we just kind of follow those breadcrumbs. Well, what causes it? What kinds of behavior of the symptoms, right? And then we're going to look for those objective findings in the lumbar or the cervical spine to lead us to believe what might be the problem. Now, could I send, let's say, you know, Truman is my patient, and he's coming in complaining about similar stuff. He's complaining about, you know, radiation going down his legs. Could I send him for an MRI and that MRI show nothing? And he still has low back problems. Yeah, absolutely. Right? I could send him for, I can't tell you how many patients I personally, but we've sent for MRIs, excuse me, and we get that MRI back and you're looking at the MRI going, I don't see anything here. Right? But then Truman's going, I don't care what you see. I'm telling you what I feel. And at that point, then we have to go, okay, let's follow the breadcrumbs. Right? Let's lean to this way. How's that feel? Oh, that actually makes it feel better. Okay, good. Oh yeah, it's getting better. It's getting better. Okay, the pain is gone. All right, let's lean back over. Oh, it's getting better. Okay, I want you to follow it. Draw it for me. Follow it all the way out. Okay, good. That can help us determine the dermatomes and myotomes so we can trace it back to maybe where the problem is in the spine. So for sure, all of that are going to be our findings as we do this. And we're going to play as much of a part in this as a PT is. Because the PT only is going to get to eval them once, right? And if Truman's being eval by Dr. Reskin, she sees him for 45 minutes. Could Truman come in that 45 minutes and not have a single symptom at that 45-minute period? Where he comes in and nothing's flared up. He's like, yeah, I've got pain normally. Yeah, sure he could. Right? It's like, you know, normally, yeah, it's, and Dr. Reskin's trying to provoke it. And he's like, no, not doing anything. No, yeah. I mean, maybe a little, right? This is that whole thing of, you go to the eye doctor and the eye doctor's like, better or worse, better or worse, better or worse. Same idea here. And Truman's like, yeah, I mean, maybe a little better, maybe a little worse. And Dr. Reston's like, man, I just can't tease this out. Now Truman comes and sees us, and we have him doing, I don't know, crunches. And as soon as he does his like third crunch, he's like, oh God, that just made that pain get worse in my back. And we're like, now we got a breadcrumb. And we can report that back to Dr. Reskin and say, hey, when we did this, this happened. And we literally become Sherlock Holmes a little bit. Discs just degenerate. That just happens, again, over time. So don't be confused if you get questions on your boards that talk about DDD versus DJD. DDD is the disc. That is the joint. So if I have degenerative disc disease, the discs are breaking down. If I have degenerative joint disease, the joints are breaking down. So typically those joints where the bones are all coming together. Both of those will happen as we get older. You can end up with what's called segmental or clinical instability, where as one area gets weak, it progressively makes other areas weak as well, or tight. Stenosis is narrowing of the canals, and it can be narrowing of the vein vertebral canal, or it can be narrowing of those canal windows where those nerve roots kind of jump out. Radiculopathy is the technical term from Medicare and from a lot of other insurance carriers, which is that pain that's being referred somewhere else. And it'll all lead to dysfunction. So what else can happen at the facet joints? We can sprain the joints. You can damage the joint capsule, osteoarthritis, degenerative joint disease. You can end up with a spondylolysis or a spondylolisthesis, where they get a bony defect or you get slippage. Rheumatoid arthritis can set in. Or you can get ankylosing spondylitis, where You've ignored the inflammation of that spine so much that the arthritis is built up and is now beginning to fuse anatomically certain areas of the spine. That can also occur at other joints. You can end up with an ankylosing wrist joint where the wrist starts fusing together because of arthritis. But ankylosing just means abnormal fusion happening. The vertebrae can be damaged from osteoporosis, specifically with fractures. There's our Sherman's disease. I knew it was coming up at some point, right, where those bones just kind of aren't nice and smooth like they should be. Soft tissue damage can occur. So the spinal musculature, primarily located dorsally, can get injured. So the back part of my spine can be injured. So the more superficial muscles would be iliacastalis, longissimus, and spinalis of those erector spinae group. And all of those muscles can be damaged by sudden violent contractions, rapid stretching, combined lumbar extension or rotation. So when we do stuff like that, or flexion, eccentric loading, repetitive overuse, or more importantly, car accidents, right? A lot of patients that we'll see in the clinic are coming to us because they've had a car accident and that has damaged the musculature of the back. And that can be of the neck, the thoracic region, the lumbar region, or all. So as we improve the patient's symptoms, whether it's a degenerative disc disease, a degenerative joint disease, soft tissue, a facet joint problem, we are going to strengthen the back no matter what. Because if we can get the back nice and strong, we can help prevent further disabilities. It can also reduce postural strain, which then eventually will reduce the emotional stress of having low back pain. Talked about radiculopathies already, mechanical compression of the nerve root. That's where the pain kind of radiates somewhere else. That's that peripheralization type effect, often termed as sciatica or pinched nerve. So we kind of covered that already. I'm not going to beat that dead horse anymore. So what are we looking at when we talk about specific areas? Well, the T-spine, the L-spine, the pelvic region. A lot of times compression fractures occur there. You can get spondylolisthesis, ankylosing spondylitis, Sherman's disease. Your ribs can actually sublux from your vertebrae. Or a lot of times, especially with ladies that are getting pregnant, they end up with sacroiliac dysfunction, where because you've had that relaxin in your hormone when you're pregnant, that SI joint becomes a little bit too loosey-goosey, and things either become hypomobile, that there's absolutely no mobility, or they become hypermobile and they rotate. So the denominant, that pelvic bone rotates either anteriorly or posteriorly, or may slip, where one side shifts superiorly or inferiorly compared to the other. At that point, we can do stuff to help with that. There is the shotgun technique, or the pelvic shotgun. Now, if you hear something called a shotgun technique, that probably sounds like it's a what type of mobilization?
Level 5.
Yeah, it's a level 5 for sure, right? Now, there are muscle energy techniques to help with that as well, where we're going to use some of those PNF techniques to rotate the pelvis in specific directions. But when we're talking high thrust velocities or the shotgun technique, most of the time those are going to be done by PTs. I can't even demonstrate them because I don't understand the pelvic shotgun technique. It's been taught to me like 5 times and I don't understand it. Like I get it. I see how it works with the patient, but I don't want to do that because it literally involves popping that pelvis while they're in the best way I put it is the bird dog position, where you have the one leg up in the air and they kind of crack the pelvis. Most patients had done, they like it, but I can't imagine it. In the upper thoracic and then the cervical spine, tension headaches are really common. I have a little bit of one tension headache from riding on the airplane because I don't fly very well. And so I could just kind of feel the back of my neck getting kind of tender. So we're going to stretch out here in a little bit. Leads to neck pain, can lead to cervical, as one of my instructors, the cervical region, cervical radiculopathy, there we go, which can lead to cervical myopathy or myelopathy, where the muscles start breaking down. Right? And even we don't think about this, but neck pain and back pain can lead to temporomandibular dysfunction, or what's called TMD of the TMJ. So this is one of my favorite, I think I've mentioned this multiple times before. So I love when people come to me and say, I've got TMJ. And I'm like, cool, I got 2 of them. You only got 1? Technically what they're saying is they have TMD, temporomandibular dysfunction, right? Or TMJD, depending upon what you're looking at. That's where the joints aren't working as well, right? That from holding your neck tight or having a tight neck can lead to temporomandibular dysfunction. And it can lead to problems where you get a tight jaw. I'm sure some of you at least know somebody that talks like this, where their mouth barely moves. Yeah, she, yeah. Right? Because they've got really kind of tight and sore jaw muscles. What are the motions of the temporomandibular joint? Well, we have opening, right? Opening, closing. We have lateral, and we have protrusion and protraction, retraction. What can cause temporomandibular pain? Well, SCMs are tied to that, right? And they're tied to our neck. So when you get neck pain, it's oftentimes you're going to end up with temporomandibular pain too. And we treat TMJ as well in PT, believe it or not. Not only do PTs treat it, but also dentists and everything else treat it as well. When we have problems with the TMD, we've got to work on reducing the pain. Wearing a bite guard at night can be really beneficial for somebody that has bruxism. What's bruxism? Does anyone know? I bet some of you do bruxism at night.
Is it grinding your teeth? When you
Yeah,
sleep? Yeah.
grinding your teeth, right? And if you're sitting there grinding your teeth at night, think of how tight your jaw has to be to do that. And then you wake up and you're like, man, my neck hurts and my jaw hurts. I don't understand what I did all night. And you're sitting around there's like, it sounded like you're making cornmeal over there with how much you're grinding. So we have to teach them how to relax that jaw, let the jaw relax, right? Facial muscle relaxation, tongue proprioception and control, controlling of the jaw muscles. There's a term that you'll hear a lot with TMJ, or 2 terms called with opening. We have early opening and we have late opening. So early opening, if you take your tongue and touch the tongue to the roof of your mouth right now, and then open your mouth. As far as your mouth can open with that tongue still touching the roof of your mouth, that is considered early opening. And then you have late opening is anything beyond that to the maximum you can open your mouth, right? That's when you go to the dentist and they're like, open wide, crank, and they open your mouth up really wide. That's kind of late opening. So you got to work a little bit of that. So work on, maybe motion in early opening where you're touching the tongue to the roof of your mouth. And you're doing lateral movement. Or you get to that early opening and you work on just relaxing your face when you're in there. Right? We actually can do stuff like blowing bubbles for TMJ. There's all kinds of fun stuff we can do. Whether we're treating the upper cervical, lower cervical, upper thoracic, lower thoracic, upper lumbar, lower lumbar, sacral, whatever we're treating, right? The patient has to learn basic kinesthetic awareness, learning where they are in space. Have a basic spinal stabilization training, where we either work on stabilizing with cervical sets or abdominal and lower spine sets. Have a functional training of the body and mechanics, showing them how to lift and how not to lift. Giving them education on what they can do and what they can't do. What to do when they're in a flare and what to do when they're in a functional phase. Reinforce that with verbal, visual, and tactile cueing. And then as we start building postural support, start integrating that into activities that we're working with them. We also have to integrate cardio pump, because cardio pump comes into play with our back. When we are working on it, we teach them deep segmental muscle activation. So how to activate the deep flexors, how to activate the lower and cervical flexors and extensors, how to activate the lower core and then the upper core, how to activate the pelvic muscles, how to tilt, how to fire off multifidi in the back to fire off that. Those are all going to be skills we're going to teach them. We're going to work on stabilization, right? So stabilization with progressive limb loading, adding weight, taking away weight, doing different variations of speed, techniques, stuff like that. And we can do that for both the cervical and the lumbar region. When we start, again, just like we start anything else, we start typically isometric and build up to isotonics. So we do a lot of rotation where we're doing isometric movements, chin tucks, isometric, and then move to dynamic movements, where we can then add manual resistance and then maybe even add weights or TheraBand as we need it. Same thing when we go down to the abdomen into the thorax, right? We can work on trunk flexion in supine. We can work on trunk flexion sitting or in standing. We can work extension in all of those. With joint mobilizations for the spine, the main thing you need to understand, they're out of the scope of practice for us, but they follow the same grades as any other mobilization, grades 1 through 5. 5s are high thrust, and they definitely should only be performed by a skilled and trained physical therapist. I would not even let a therapist that's not the best at them perform a high velocity thrust maneuver on my spine anywhere. I want somebody that's done this on a regular basis because it's really easy to screw up your back, right? It's why I'm always a little leery about chiropractors just adjusting me for everything. We can manipulate the ribs and move the ribs to help with inspiratory restriction or expiratory restriction. We can help learn how to elevate that first rib, but all those are going to be manual techniques that are going to be more out of the scope of practice of us and more in the scope of practice of the PT. So no matter what, the joints in the spinal region, same joints that we have everywhere else. Same bones, ligaments, tendons, everything we experience, everything else. That means we treat them the same. They're going to damage and heal the same way, right? If the patient injured their back 25 years ago, that's not an acute injury. That's a chronic injury at that point. They may think they're forever damaged, right? But that's a factor of belief, not of evidence. Now, they can be have a greater propensity of re-injuring that area. But if we work on strengthening, we can help them prevent re-injuring that area. Because of the proximity of spinal nerves, we do have to be a little bit careful, but the spinal region is not nearly as fragile as you think it would be. So you're not going to immediately paralyze somebody by stretching their neck. Fear is the largest factor for both patients and clinician treatments. How many of you guys would say that you would be scared to work on a patient that had a cervical issue? Okay, good. That's okay. It's okay to be afraid of that. I was terrified the first time I ever worked on a cervical patient because I'm like, man, I could screw something up. And then once I got hands-on with that patient, I'm like, okay, well, I really can't mess unless I like grab a hold of John's head and, you know, do a whole like Jean-Claude Van Damme twist and snap. I can't really break his neck. It requires a lot of force to do stuff like that. So that means knowledge is not only power, but it's also the antidote to fear. Telling patients it's okay to hurt. It's understandable. I know you're hurting, right? But teaching them what to do and what not to do, as well as us what to do and what not to do, and when to ask for help is key to making sure you're comfortable with this. It's also power for the patient to unravel their problems and their symptoms. You know, you may be asking a patient, so when does your neck pain hurt? And the patient's like, oh, when I stick my neck out like this. And then they're like, all of a sudden this light bulb comes on like, why am I sticking my head out like this in the first place? That doesn't even make sense. Oh, well, I don't have a problem when I'm back like this. I probably should keep my head back more often. And something simple as that can make the patient realize they're being a little bit of a dum-dum head. Activity and motion is key for spinal recovery, pain modulation, and overall healing. Motion is lotion. They have to move. Pain should not be the only limit to stopping from moving. Yes, we all have pain. I am in pain right now. I'm sore, I'm achy, I hate flying, I'm grumpy. I'm still here teaching you guys. I didn't use it as an excuse. Now, the other day when I had a migraine, that was legitimately an excuse to miss the day because there was no function at all that day. But you as a clinician need to learn how to understand what their pain is saying. You need to understand, when is there a red light? Stopping, right? Oh my God, my peripheralization or my pain going down my arm is getting worse with that technique you're doing. Red light, I need to stop, right? Oh, it's a little uncomfortable. Okay, yellow light, right? I may have to modify it and not be pulling as hard on them. Oh yeah, okay, that feels good. It's a little painful, but oh my God, that feels good. Keep going, right? Or, hey, my arm pain went away when you stretched my neck that way. Green light, keep going. All pain is neurological in nature. It's all in the brain. It's just the body's way of warning us. A mechanical generator may trigger the pain, but it is triggered in the brain itself. So tissue damage, injury, compression, etc. can be the trigger for it, but it is neurological in basis. It is all kind of in our head, right? But that doesn't mean that tissue damage itself causes all pain, right? Neurological conditions can create pain. Neurological conditions can also decrease symptoms and pain. It's a byproduct of the neurological system's assessment of danger, right? Whether it's real or merely potential, because patients can have psychological pain that isn't in alignment with what you're seeing. They can have abnormal responses to pain that have nothing to do with what you're looking at with them. So you have to be aware when to pay attention to those things. One of the things I find with my spine patients is keep it simple. Develop a verbiage or a script. Use it all the time. Trust me. So first question to the patient. As a result of your exercise, your pain better, worse, or the same? Did you even do your exercise? What did they do? Can you demonstrate your exercises to me? Watch them and see how they do them. Correct them. Make sure they understand the proper way of doing it. After doing this exercise the proper way, is your pain better, worse, or has it moved, or is it the same? Oh, okay, where do you feel your pain? Is it central? Is it down your legs? Is it down your arms? How are you is a great question, right? So how are you doing today? That's a really kind of general question. It can help you build rapport, but it can also lead you down paths that may be completely irrelevant to what you want, right? If I walk into John and I'm like, John, how you doing today? And John's like, well, yesterday my wife left me. My dog took my truck and ran away with my truck. I'm losing my house because of a tornado. I'm here to see you about your foot. I just got tons of stuff that really have nothing truly. John just needs somebody to talk to. Exactly, right? So you kind of have to be aware of that and watch what you're saying and develop a script that kind of keeps you on track. Remember, if a patient, it's been a tough year, exactly. If your patient tells you, you're like, so on a scale of 0 to 10, how's your pain level today? And your patient says 9, that is not a time to say, well, that's great. I'm going to punch you if you tell me that a 9 out of 10 is great pain. Right? Or that's good. Okay. Well, that's fantastic. Right? We say those positive and reinforcing things, not thinking that we're saying it. At least it's not a 10. Yeah, right? So be aware of what your responses look like as well. Okay, so your pain's in 9 out of 10. Okay. Is it constant pain, like it's always there? Does it come and go? Oh, it comes and goes. Is it better or worse at any time in the day? Maybe in the morning, afternoon, night? Oh, it gets a lot worse at night. Are you on any medications that help it? Oh yeah, when I take my anti-inflammatory, it really helps it. Okay, I'm getting breadcrumbs, right? How about when you exercise? Does it get worse? Well, no, actually when I exercise, it gets better. Oh, okay. Does it get back after you stop? Yeah, how long does it take? Oh, about 20 to 30 minutes. Okay. Does the intensity get worse after you stop, or does it come back at about the same level? You see how that kind of that script that I developed there leads me down this path that kind of traces a route, and I can follow it every time, and I don't get deviated. And my patient doesn't control the conversation then. I control the conversation. I get what I need, and I'm able to get in and out of that response pretty quick. Patients, here's the thing. I know I have a lot of patients will complain. Patients will complain. Patients will complain about everything. It's just the way it is. That's life. They're going to complain that they're sent to us before an MRI. Well, it's because docs are going to look for an easy, less invasive treatment first. It's probably better for a patient. MRIs aren't always 100% accurate. It's not magical. They're also expensive. They're in a tube that makes lots of noise, right? And pain can present even when there's no structural damage. They'll complain when they're sent to PT before surgery. But if they have PT before surgery, the surgery at the end comes out better. This is what always gets me, the patients that are surprised that they're in pain after surgery. Like, to me, that just blows my mind. Well, I went in for surgery, I thought my pain would go away. So you thought that if a doctor went in with a bone saw, drill, and screwdriver, that you wouldn't have any pain when you come out. Really? That's what you thought? Really? Right? So, yeah, right, John, it's amazing. I thought I'd be pain-free. And you're just like, okay, my head just exploded there a little bit, right? So surgery is controlled trauma. Your body is not a car. You can't replace parts. I'd love it if we ever get to that point where we can just be like, go down to AutoZone. I need a new heart, a new kidney, and a right foot. And we just kind of disconnect those parts, reconnect them, and go right back to it. But we're not there yet. Cyberpunk, exactly, right? Someday we'll be there, Anthony. Someday. And some patients will improve immediately. And this gets frustrating for patients too. They come up to the gym with a group therapy, and you've got little Millie who's 95 years old, and she's up and moving around, right? And then you got, Jamie over in the corner who's just dragging his butt and can't even get out of bed, and he's 30. We all heal differently. Some of us are whiny babies when it comes to healing. Just is. Patients can alter their surgical outcomes by being compliant. If they're non-compliant with surgical instructions, it can lead to bent screws, bent plates, rods, replacement surgeries. It can also increase the risk of nosocomial infections and other infections that go along with after the hospital, and surgical outcomes and problems there. So we need to pay attention. Patient needs to be informed every time they come in. Are you following your protocol? Are you doing what the doctor said? Are you changing your dressing every day? So what kind of surgeries can they have? Well, they can have spinal fusions, where we put plates, rods, pins all along the vertebrae. We can have bone grafts along that spinal fusion, so designed to stabilize spine. This one over here is a pretty big spinal fusion. That's quite a few spinal vertebrae fusions. Now, the key thing about a spinal fusion, what do you think is going to happen? Let me change the color here. What do you think is going to happen to these vertebrae up here over time?
Weaken.
Yeah, they're going to weaken and become hyper or hypomobile depending upon what happens, right? So that means in a few years, surgeon's going to have to go in and do that. And then in a few years, have to go in and do that. Because over time, like for example, in my neck, right? Because I've got 4, 5, 6 fused. So, and I've got 3, 4 fused naturally, congenitally. That means all my motion's occurring elsewhere in my neck. That means those areas are handling all of the motion in my neck that I have, right? And then they turn into Robocop, exactly. As those areas break down, they're going to have to be replaced too, which is going to reduce my motion, right? So those areas stressed above and below can lead to long-term fusions down the road. We can do a laminectomy where we go in and snip out part of the lamina to open up space for things to breathe, right? Give more space for the nerve root in case of stenosis, create space for discectomy. When you do that, though, the vertebral integrity is altered, which means it can lead to fractures down the road. Most patients that have spinal surgeries are going to have some sort of bracing after surgery. And the main idea for the bracing is to keep them from cheating and breaking their precautions. Doesn't matter if it's upper cervical, lower cervical, lumbar, the precautions are all the same. The BLT sandwich. No bending, no lifting, no twisting. And especially no bending, lifting, and twisting together. So in the case of my neck, when I had my neck surgery, I had the brace on there. I wasn't allowed to turn my head, right? I wasn't allowed to side bend, and I wasn't allowed to lift up. And I definitely wasn't allowed to side bend, lift, and do whatever at the same time. That puts a ton of stress on those areas that just got fused. So here we have a TLSO on this patient, thoracolumbar stabilization. This one actually has a little bit of a sacrum down here. You can have just a TLO, thoracolumbar orthosis, right? You can have a small, what's called abdominal binder. And all that does is helps with posture. And here we have one of the fun devices. This is called a halo. I wore one of these for 9 months with my first time I broke my neck. And we'll talk about that next semester, but the halo is a fun device because what you can't see here is in all these little areas here, there are screws. And where do you think those screws are going?
Your skull?
Yes, into your skull.
How do you sleep with that?
Not very well. With lots of pain meds. Actually, you become used to it after a while, to be 100% honest. Like the first week or so you have it, it sucks and it's a lot of pain. But you can't shower. And most of them have sheepskin underneath the vest. And so that gets pretty funky after a couple months. So needless to say, you're not going out on many dates wearing that, that halo. I'm just saying. But the goal of the halo is to keep you from dying. So I guess, you know, wearing the halo is a good thing rather than dying. All right. Let's talk about stretching the neck, because we all need this to finish the day out. I think we're all kind of tight and tired. So let's work on just talking about stretching the neck in case you're in the clinic and you encounter this. So all of us carry tension primarily through our upper traps, our levator in the back, and that suboccipital triangle in the back. That's our primary areas of traction or problem that we have tension in. We also carry it here in our scalenes and our SCM. So let's go piece by piece how to stretch the neck. Let's start with the big muscle. So we're going to start with upper trap, right? So if I want to stretch upper trap, I'm going to tilt the camera down just a little bit. Okay. If I want to stretch upper trap, what I have to do is put it on maximum length, which is also known as what? Maximum length is
Passive insufficiency.
passive insufficiency. Good, right? Active can't shorten anymore. Passive insufficiency can't lengthen anymore. So let's think about upper trap. It goes all the way out here, right? Goes all the way up to my neck, up in the upper cervical region. So what I'm going to do to stretch my upper trap is we're going to stretch our right side first. Take your right hand, you're going to place it behind your back. You can grab a hold of a chair if you'd like, or you can just put it behind your back if you're tight. The goal at that point is to depress that inferior angle or the acromion process out there of the scapula. You're then going to take your other hand, bring it up and across your head, and you're going to pull laterally only. And so you're pulling your left ear to your left shoulder. I'm actually going to switch because the headsets are getting in the way right now. So let me change my audio here. So I can take my headset off. There we go. So come in here, ear down to the shoulder. We're going to hold that for 10 seconds. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and then let up. And let's do the other side. So head up and across, other arm behind your back, ear down to your shoulder. Once you're there, we're going to hold for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and come out of it and relax. Now, normally we would do that 3 times. We're just going to do 1 of each. So I've got my upper trap stretched out. The next one I'm going to work is my levator, which works in conjunction with that upper trap. It just means you're super tight, Bianca. Yeah, your delts are probably irritated with it. That's okay, right? That just means you got to stretch a little bit more, right? This feels nice, right? So now we're going to work levator. I'm going to start working right levator, and then we'll work left levator. Little bit of a different posture. So what I'm going to do this time is take my right hand. I'm going to put it up here on my shoulder. All I'm doing is resting it up here. I can rest it here. The idea is now to elevate that part of my acromion. I'm going to turn my head 45 degrees away. So I'm working right side here. So I'm turning 45 degrees to my left. I'm going to grab a hold of my forehead and top of my head and look down into my pocket. So I'm at a 45-degree angle coming down like this. We're going to get down there, and we're going to hold for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and relax and come up off of it. That feels nice, right? So same idea, take your left hand, rest it up here on your shoulder, 45 degrees to the right. Get a hold of your head here, look down into that right pocket. Get it in position, and we're gonna hold. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and we're going to come up and off of it. All right, so we've got those 2 big groups kind of stretched out. Yeah, we're going to find out what side's tight in you for sure, right? So now we've got upper trap stretch, we've got levator. Let's get our scalenes. So first one we're going to do is I typically work my anterior, then I go to middle, and then I go posterior. So I'm going to turn my head slightly, like that 45-degree angle that I had before. And I'm going to look up. I'm going to come here just slightly under my chin and give a little bit of overpressure going up. You should feel a pull right in through here. And once you're in that position, we're going to hold. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. It affected my voice the whole time doing that, which means your scalenes or SCMs are probably tight. We're going to stretch those, don't worry. So let's turn the opposite way. Look up, come under the chin, a little bit of overpressure. Get that position and hold. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. You can add a different technique to that when you're doing that one. So if I'm over here, I can come here and take this hand and pull down at the same time. But that's a little bit more of an advanced technique, and you guys aren't stretching on your SCMs yet, so I don't want you to rip those out yet. So anterior stretched a little bit. Let's stretch middle. So remember, when I leaned this way, I had my scapula depressed so that I could stretch that upper trap out. Same position we had now with levator. We're going to put that hand up here on the shoulder again. And now we're just going to lean that shoulder down to the ear. You should feel a little different where it's more on the neck itself, less on the upper trap. So arm up like this, ear down to the shoulder. And we're going to pull. Now it's in position. We're going to hold. 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. And we're going to come out of that. We're going to change positions. Left hand on that left shoulder, right hand overhead. We're going to pull down that right ear to that right shoulder. Oh. And once we're in position, we're going to hold. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and come off of it. All right. So now we're going to do a little bit of a combo SCM and posterior scalene stretch. What we're going to do is you're going to turn your head one direction, pick either to the left or the right. I'm going to start turning my head to the left. So I'm at that 45-degree angle to the left. I'm going to lean my ear down and forward. So I'm kind of coming at that motion there, down and forward. So I'm doing a little bit of rotation and bringing it down. Once I do that, I'm going to take my right hand up here and I'm going to pull it further down and forward. So the ear is kind of coming down towards my pocket. And we're going to hold that once you're in position. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and then come up off of it. Okay. Now turn your head to that right side. Same thing, you're going to dip that ear down towards your pocket. Come up with the left hand, pull it deeper down into that pocket. And we're going to hold that. Get in position and hold it. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and come up and out of it. Starting to loosen up a little bit for some of you. Okay. The next thing we're going to do is we're going to put our finger on our chin, right there, kind of on our mental foramen. They're a little painful, right? Especially if you've got a really, really tight scalene, or not scalene, SCM. They're going to be pretty painful. We're going to put a finger on our chin, and what we're going to do is we're going to try to pull our chin back as far as we can, so we kind of get that triple chin going on. And once you're back there, put a little bit of overpressure, and you're going to hold that for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and come out of it. Now you're going to do a similar thing, but just slightly flex your head forward this time. Once you're slightly flexed forward, do the same retraction and the same bit of overpressure. So you're pushing backwards and up this time instead of just straight backwards. You're going to hold that. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So we're stretching out that upper cervicular musculature up in the back, that kind of suboccipital triangle region. Did you feel a little bit of a pull back there, Truman? Right? We're taking kind of that rectus, the rectus capitis, and all those and kind of putting them on a little bit of tension. Okay, so last is kind of a pure SCM stretch. Remember, with an SCM, side bending 2, rotation away. That's kind of what we did with this. This time, though, when we do this, I want you to kind of place one hand up here and get the second hand kind of a lock on the chin. Now, we are not going to do one of these. You're not doing a rapid rotation. You're going to do a gentle pull with the top hand and slight push with the bottom hand. Do not yank or you will strain your SCM. So here, lock it in on your chin. And just do a little bit of extra push. So I'm pushing this way with this hand, pulling this way with this hand. And we're going to hold that for 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. Come out of it. Oh, that actually caused my vision to get blurry. Same idea, lateral flexion, rotation away, up and over, chin lock, going this way and this way. Get it in position, feel that nice pull. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and come off of it. All right, we're going to do one more stretch and then we're going to roll it out. Now let's take both your hands, place them behind your head, and what you're going to do is flex your head forward. And with these hands, you're making this type of a motion. You're not pulling straight down, forcing my chin into my chest. I'm doing a rotational movement. So I'm coming back on that occiput and rotating my head down. You should feel a pull kind of the whole length of that erector spinae back in the back part of your neck. So rotational. And once you're in position and feel a good pull, we're going to hold it. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And slowly come up and out of it. All right, and last thing we're gonna do for the neck to kind of loosen it back up is we're gonna roll it. So we're gonna start with the chin tucked, and we're gonna roll to the left side and around. And we're gonna roll 5 times each way. So there's 1, 2, 3, 4, 5, and then we're going to rotate the opposite direction. 1, 2, 3, 4, 5. And then bring yourself back to neutral. And what I want you to do for a few seconds is focus on your posture. So think of your head nice and neutral, shoulders back. And we're going to do 3 good deep breaths from this position. So we're going to breathe in through our nose, out through our mouth. 1. In through our nose, out through our mouth. 2. And then 1 more. In through our nose, out through our mouth. 3. And then just be posturally aware for a few seconds. Feel all those muscles you just kind of stretched and strained a little bit. Acknowledge them, know they're there, and then come back. How did that feel? Favorite TherEx class so far? Do you guys feel more relaxed after that? Riley's like, really good. Time for a nap. But I'm now a chair. I love it. Instructions unclear. All right. Well, the good news is, need one for the lumbar. We're gonna do a lumbar one in class. It's just harder to do that virtually than it is the neck one. The neck one's easy to do virtually. Right? That everything kind of feel relaxed from about chest level up. And then if you wanted to, you could add in afterwards a nice opening of the chest and stretch open that whole pecs if you wanted with the patient. But what you just basically did was loosened everything up. And sometimes, like me, I did have a little bit of a cervical headache coming in. Just by doing those couple exercises, I definitely can feel that cervical headache has kind of tamped down a little bit. It's not as intense as it was. It is. Again, people are like, was the bone cracking? Nah, maybe. It could also be the capsules in your neck kind of getting rid of excess lactic acid and stuff like that. Who knows what's actually causing it? As long as it's not causing you pain when it cracks, not really overly concerned with it. You know, if it's like, oh, now I can't move, that's a problem. Oh my Lord, I lost feeling in my arm. That'd be bad. All right, I'm gonna stop recording now that we've relaxed our body.